Hello, and thank you all so much for joining our national Improved Medicare for All Forum this weekend. We're doing it 3 days. We have 11 panels, musicians, a bunch of exclusive interviews, some cameos, and so much planned. So, first, I want to give a shout out to all of the people, our panelists, musician, hosts, but also all of the people behind the scenes that you guys never see. This has been a work in progress for months, and there's so much behind the scenes. So shout out to all the team members who are there. We acknowledge you. We love you. So tonight we have, I'm going to pass it to Luke Parcher. And he will be hosting the first panel with 3 people. Then I will be doing the next panel with 3 other guests. Then we are going to see an exclusive interview I did with the only literal Bernie bro, Larry Sanders, who was the healthcare spokesperson in the UK for the Green Party, and then also a video from UK streamer Cavernacle. After that, we have a live performance from Jessie Jett. So a lot going on tonight. It starts now, but please stick around till the end of the events tonight and tune in the next 2 days as well. So I'm going to pass it over to Luke.
Thank you so much, Joy, and it is such an honor to be a part of this summit this weekend. For those who don't know me, I'm Luke Parcher. I'm with Real Progressives and Real Progress in Action. I'm a volunteer, and I'm on our leadership team. I'm a student, activist, and political commentator, and I am just absolutely thrilled to be a part of this summit. Thank you all so much for tuning in. I do want to quickly shout out all of our sponsors: March for Medicare for All, Physicians for a National Health Program, Real Progressives, Yellow Vest Actions, and Indie Left Media. Thank you so much to everybody who put this all together. And without further ado, I would like to introduce our fantastic panelists here today. So we have Dr. Anna Malino. Dr. Anna Malino is a retired professor of pediatrics from the University of California, San Francisco. She's the past president of Physicians for a National Health Program and a lead organizer for the National Single Payer Steering Committee. Anna, thank you so much for taking the time to be here today. We also have Dr. Ted Brown, who is Professor Emeritus of History and Public Health Sciences at the University of Rochester, where he taught for 42 years. He served for 25 years as history editor of the American Journal of Public Health and has co-authored books on the history of health reform in the United States, the American left, and the World Health Organization. Ted, thank you so much for taking the time. And we also have Dr. Stephanie Woolhandler, who is a distinguished professor at the City University of New York. New York's Hunter College, a primary care doctor in the South Bronx, and a lecturer of medicine at Harvard Medical School, where she was formerly professor of medicine. Steffi, thank you as well for taking the time. So just so that the audience understands how we're going to format this, each of our guests today has a presentation to go through. We're going to start with Ted's presentation on the history of health policy in this country. And then we're going to get Anna's presentation going into some of how the system currently operates. And she's going to show you how the healthcare system is divided up. And then we're going to finish with Steffi's presentation on the privatization and the harmful effects of it. I'm sorry to see that we may have lost Anna there. We'll try to get her back as quickly as possible. Just quickly for the audience, we are going to do a Q&A at the end of this panel. So if you'd like to participate in the Q&A, please put your questions in the chat box, and we will have people watching for questions to ask our panelists after they present today. And without further ado, I will pass things over here to Ted to begin his presentation.
Okay, let's get the slides up if we can. There we are. I'm going to try to really tackle this topic. It's a very large one from a very thematic perspective. Instead of trying to give you all the nitty-gritty, I'm going to give you a broad overview, which is that if we look over a century or more of health policy struggles in the United States, we can see it as a battle against red baiting and the labeling of any progressive program, especially at the national level, as socialistic or communistic. And I'm going to not only focus on that theme, I'm going to use a lot of illustrations that are going to include some photographs and a lot of cartoons, but I think they will effectively make the point. So let's get started. And a good way of framing it is to begin with the first slide. There we are. I hope you can see it. It's a very broad perspective on the end of the world as we know it. Moments of panic on the part of the American elite and the American established interests, who at various times in the 1790s were facing the threat of public schools and then public water systems in 1808, etc., right on through when this cartoon was first published in 2009 at the launch of the campaign for Obamacare, with the attempt to get a national health program yet again. And the constant refrain was, oh my God, the world is going to end as we know it. But this is really an optimistic perspective. Not only does it underlie the tactic that's used, but it also expresses some optimism, because all those fears in the past about public water systems and public highways and public schools were overcome, and those were established as major American institutions. The notion is in 2009, we're facing those fears again, we're facing that labeling, but maybe we can finally optimistically move forward. As we can see, it didn't turn out quite that way. This cartoon leaves out a couple of other major red baiting episodes in the history of American policy. We look at the next slide. Back in 1965, when Medicare was going to be put into effect after a long uphill political battle, it was, of course, labeled as socialism on a socialist plot. And the cartoon conveys the notion that nothing new, 30 years before, so was Social Security. So seen, those obstacles were overcome. But this refrain is an important theme to focus on. If we look at the next slide, we can put things in an ironic historical perspective. Because, in fact, the very notions of social insurance, of health insurance built on social insurance models, goes back to the late 19th century and to the policies of Otto von Bismarck when he was chancellor in Germany. And ironically, he intended these state measures as alternatives to socialism, as a way, as he puts it, if you can read the small print on the slide, to bribe the working class away from the seductions of parties on the left and the great threat of communism and socialism, and have them become loyal to the state because of the benefits that were provided for them in their old age, when they fell sick, and so on. And his strategy was quite successful in that he did avert what might have been seen as incipient revolution in the late 19th and early 20th century, but it didn't work in the sense that those very policies were adapted by socialist parties working within the democratic context and gaining increasing seats in the German Reichstag, their parliamentary organization. And so they were able over decades to move to policies that were more reflective of working class desires and needs. And instead of wooing them away from socialism, it made them loyal to an elective socialism and the policy that grew steadily to support those measures as part of national policy. Those policies and those approaches were introduced in the United States essentially by this man. He wasn't the only one. Next slide. That's Isaac Max Rubino, who was an immigrant to the United States. He was originally born in Russia, but he was educated in Germany, learned in great detail about the German social welfare system and the kind of measures that Bismarck had introduced. And when he came to the United States, became a founder of the American Socialist Party in the early 1900s, and became a very important leader, holding government positions as an expert on the German and then widely European social insurance measures for covering workers' sickness, workers' old age insurance, workers' compensation when they fell ill on the job, and that sort of thing, and became a national leader with those goals in mind. The ideas were picked up, next slide please, in significant numbers by the American labor movement, and in particular by unions that were led by women, very powerful and impassioned unions. And you can see in this cartoon from the early 1900s, a very important woman figure in the front, the maternal figure, who is the strength of a family. And she is cautioning them that they should provide protection against destitution and illness by protecting themselves with the umbrella of health insurance that they would push for to be created as a state policy. And this was a very important part of the labor movement in the early 20th century. That campaign was taken up by an organization called the American Association for Labor Legislation. Next slide, please. Which was not led so much by women leaders, but rather by male leaders. And you can even see in the change of the figure here from a powerful woman figure to male figures as the principal characters here. A message is being told in this cartoon. The American Association for Labor Legislation will push for workmen's compensation, will push for sickness insurance and other measures to protect workers against the various infirmities and dangers that they were exposed to. England was far ahead. That's the worker on the left with a very full umbrella. The American worker at that point had only workmen's compensation, not very full coverage. And the message of the American Association for Labor Legislation in this campaign was to try to emulate what had already been done in Britain as the Labour Party grew in Britain as a democratic socialist institution within the parliamentary system. If America could move in that direction, it would be a very important advance for American workers and their protections. That campaign was picked up by 1912, next slide please, by Teddy Roosevelt, who at that point was running as the Progressive Party candidate for president. He had already been US president as a Republican, broke with the Republican Party, didn't agree with their policies, and this was the convention that officially nominated him in 1912. That convention not only chose Teddy Roosevelt to be his presidential nominee, but it also adopted a platform which included sickness insurance, health insurance as one of the major goals to be achieved by American policy. And there was a great deal of energy and enthusiasm coming out of that convention. The Progressive Party didn't win. Woodrow Wilson was the successful candidate in that election. He didn't support those policies. But the ideas of promoting a health insurance program were taken up by others, were even taken up by progressive leadership in the American Medical Association and by others in the American political environment, so that support for it grew steadily in the 19-teens at the state level. Some states got very close to passing sickness insurance, health insurance at the state level, others not so much. But then the campaign foundered with America's entry into World War I. And you can see some evidence of this indirectly in the next slide. The old red baiting tactic, the socialist labeling tactic, was here in evidence in a pamphlet that was published in about 1917, 1918, claiming that labor's attitude towards compulsory health insurance was really quite negative. Someone alleging to speak for labor, Mrs. Sarah Conboy, claims that workers didn't want compulsory insurance. The very choice of language makes it seem negative and Bolshevistic and collectivist. And it was also a time when America was just entering World War I, and our great enemy was Germany. So anything associated with Germany, like Bismarck's insurance measures, would be considered as negative. It would be socialistic, it would be collectivistic, it would be compulsory, and it would be German, all things that were sufficiently negative and used symbolically and manipulatively in the political environment to really very rapidly reverse support that had been building up for national health insurance in that decade and squash it. With the coming of the Russian Revolution, a major Red Scare in the United States in the late 19-teens and into the 20s, these ideas just were thrown out of consideration. And only slowly by the later 1920s did they begin to come back. So by the late 1920s, it was possible again to debate the merits of national health insurance, sickness insurance, versus the continuation of the American system that was argued in the pages, for example, of The Nation magazine. If we see the next slide. Rubino had been invited to make the case for national health insurance. And then he was answered, as The Nation tried to maintain a balanced debate, by Morris Fishbein, spokesman for the American Medical Association, who, of course, used the tactic of labeling it as socialized medicine and describing it as robotic, automatic, not personal enough as we would want our medical care to be. And that's captured here in this robot figure that really is the very negative image of what would become medical care under a so-called socialist system. But there were still those in favor of it, and by the late 1920s, a large consortium was created called the Committee for the Cost of Medical Care. Please, next slide, please. Which pulled together leaders from the social sciences, from medicine, from public health, to try to examine the American healthcare system as existed in the late 1920s and early 1930s, and to make a very gentle, modest case for moving to new forms of organization to eventually consider, on a local and maybe eventually a national basis, a national system of health insurance. They issued a final report, this committee that met for many years, in 1932. And that report was very modest and cautious and careful, and yet the American Medical Association was waiting to jump on it, as it did, as you can see in the next slide. As soon as the final report was issued, an editorial was published in JAMA, the Journal of the American Medical Association, which said such things as these. You may not be able to read the fine print, but I'll read for you some of the principal language. Those who are pushing for even gentle experimentation, mildly, carefully, are nonetheless forces representing health officialdom, social theory, socialism, and communism, inciting to revolution. And repeating that language, these modest recommendations are really an incitement to revolution, and we in America must mobilize against these terribly un-American, dangerous, socialistic, Bolshevistic tendencies, that being the now very common strategy. Those threats were so great that when President Roosevelt, Franklin Roosevelt, put forth his Social Security measures in the mid-1930s, he was very careful, against advice of some of his advisors, to leave out any mention of health insurance as part of that. If we're going to get Social Security through, if we're going to create retirement benefits and other essential Social Security measures, we cannot possibly include any reference to health insurance, because the mobilized medical profession, the commercial insurance industry, will take that language again and use it to squash not only any thoughts about health insurance, but about Social Security in general. So Roosevelt backed away, and only a few years later, in the later 1930s, when he was assured that Social Security wouldn't be shot down and it would stay as an important American piece of social legislation, only then, in the late 1930s, did the idea of health insurance, national health insurance, begin to resurface. There were important spokesmen in the academic world, in the medical world, who came forward and started promoting it very vigorously. One of the most important of these was a man called Henry Sigrist. Next slide, please. Who was a professor at Johns Hopkins with great credibility, who was a medical historian and a health policy advocate. He would not only promote the idea of a national health insurance program, but he would accept invitations to go to labor forums and people's forums to promote the ideas. This was an advertisement for a forum he spoke at in Philadelphia in 1939. He was presented by Time magazine as one of the great leaders and presented with great enthusiasm by Time magazine. And yet the AMA was still, and the other opponents were still ready to use all the old tactics of red baiting and anti-socialist labeling, as you can see in the next slide. By 1939, the first measure was introduced by Senator Wagner, liberal senator from New York, beginning of a series of measures that were introduced over the next decade or so. But the AMA immediately descended on Congress, and at the testimony about the bill, as these two gentlemen represented the measures, which were very modest, as revolutionary, Bolshevistic, and the like, and that language was used, of course, with great political effect to stymie progress towards that legislation. World War II then happened, and moving forward very quickly. all those discussions were put on hold. In the post-war period, though, by this time, Harry Truman has succeeded Roosevelt, who died in office, as president, and Truman had become an advocate for the Wagner-Murray-Dingle bills, as they were called, trying to create a national health program. As soon as that legislation was introduced, as soon as President Truman began to advocate for it, the forces against it lined up, as we can see in this cartoon from the late 40s. The notion of health insurance is immediately labeled as socialized medicine, and that's meant to be some pill that an academic figure, the mortarboard, will try to shove down the throat of John Q. Public, the taxpayer, and have him choke on it, because that's what people do with socialism and such measures. Then, a little bit later in the 40s, as Great Britain, next slide please, was moving to its National Health Service, a creation of the post-World War II period in Great Britain, that was taken by the opponents of any such measures in the United States, or much more modest versions of that, as dangerous signs, warnings, and so we should worry about treading on the thin ice of socialized medicine, beware of the British example, and don't allow the United States to move in anything like that direction. With the Cold War in the late 40s and early 50s, in the McCarthy era, those tactics became even more vigorous, as we can see in the next slide. And there's a figure of Uncle Sam naively dozing and not noticing that Russia's great aim is to destroy America, using the mechanism of socialized medicine as one of the dangerous weapons that would undercut the entire American system. If you look closely at the hand holding the shears read socialized medicine, will cut off Uncle Samson's locks and have him lose his power. And the hammer and sickle is on the sleeve. It's a Bolshevik plot against the United States. There is no rational discussion in the hysterical atmosphere of the late 40s and early 50s. The next president of the United States following Truman is Dwight Eisenhower, who is, as you can see in this quotation, flatly opposed to the socialization of medicine. He's bought into that. He believes that any movement to a national health program is socialism and Bolshevism, and he will have none of it. What he does support are certain tax measures that will benefit the distribution of insurance via commercial means, an employment-based system in individual industries and workforces in which the insurance is provided primarily for profit by commercial insurers, and all that is meant to be a bastion against socialization and the inappropriate government intrusion. And that works fine for a while, but it creates what we can see as a dialectical process, because in the very process of ensuring more and more workers through employment-provided insurance spreads, inflation increases, and those individuals who are least able to pay for care and are becoming most sick, that is the elderly retired, are those in particularly difficult straits, because they now face having to buy care after their period of employment and coverage during work with union support, as well as management provision. And now they are facing a very rapidly inflating healthcare system, and this means that they are in deep trouble. But that deep trouble inspires a political response. And the political response is to create something that we begin to call Medicare. The first measures, legislative measures, that will provide a Medicare system that is a universal national system for a particular age group, those in the retirement age, 65 and older, begin to be put forward in the late 1950s. And as we can see in the next slide, Congress at first ignores them. The elderly, why do they matter? Until Congress discovers that the elderly are a very well-organized political group with a lot of labor support, and Congress begins to worry that they've got to do something. We will fast forward into the early 60s. John Kennedy runs on a pro-Medicare platform. He wins. His administration in the early 60s begins to promote Medicare. There are bitter battles about it, with the familiar suspects lined up against the American Medical Association, all the red baiting language is being used, all the conservative political figures in alliance with them. But the forces in favor of Medicare are also well organized, labor being very important in funding and organizing support. As you can see in the next slide, which is a photo of a big rally in Madison Square Garden supporting Medicare. President Kennedy actually spoke at this rally in favor of it, and that helped build support for Medicare, which grew despite the opposition and despite the familiar language and labeling that occurred against it. As you can see in the next slide, one of the spokesmen for the opposition forces was Ronald Reagan, who speaks out against socialized medicine. But even with that opposition, the forces in favor of Medicare grew, and Medicare was approved legislatively in 1965 and approved along with Medicaid, thus creating this strange system that covered part of the population, but certainly didn't create a universal system, and for many was seen as a caution, an antidote to creating a universal system, because you picked off those who were particularly vulnerable. They would be covered under their own special system, while the rest of the system remained as it had been, provided by commercial insurance, employment-based, and the rest. And yet there were some far-seeing political leaders who saw that they could build on Medicare and began to advocate an early version of Medicare for all and to create a national health program on a single-payer Medicare basis. Among those leaders was Teddy Kennedy, and there was strong labor support. So by the early 70s, there were lots of debates and lots of consideration of a national health program. So much so that some form of national health insurance by the mid-70s was seen as inevitable. The only question was what form would it take rather than whether it would happen at all. But in the 1970s, there were major economic problems. Medicare was built on very foolish foundations. There's a political explanation for that. And there was open-ended inflation. Medicare was seen as a major problem rather than as a model for extension. There were other major problems in the American economy, the oil embargo, and the rest. And all discussions in favor of a national health program ended by the late 70s. So when Ronald Reagan was elected president in 1980, he was, of course, strongly against it. And his admirers, as you can see in this next cartoon, admired the very antithesis that he so vigorously advocated against government involvement in all kinds of social policies, including in health policy. There's health reform as we would like it, say the conservative political figures. No government involvement, limited government generally. And the Democratic Party at that point was frightened enough by the changed political environment to not even advocate for national health insurance in either 1980 or 1984 in its presidential campaign. The Democratic Party only came back to a national health insurance advocacy in some form in 1988, and that was after Jesse Jackson had led a powerful primary campaign in that year's primary election. Next slide, please. And Jesse Jackson strongly supported national health reform, supported a national single-payer model. This was the time when the Physicians for a National Health Program were becoming an important political force, when that organization took the stage and became a very influential part of the American health policy discussion. Steffi and others can say more about that later if they would like to get to that. But this is the moment in the late 1980s which forces the Democratic Party to start advocating for health reform again, but they do it in a very moderate and middle-of-the-road way. Dukakis is the nominee in 1988, and he has a very different version, not a single-payer version at all, but it can be portrayed as health reform. And then in 1992, Bill Clinton advocates a form of health reform. They are very much not single-payer, not uniform Medicare for all, but they do suggest that there are some ways of getting to national reform. But those approaches get quickly lost, captured in the next cartoon, which is supposed to represent Hillary Clinton leading the task force. getting lost on stairways to nowhere. This, of course, is a takeoff on the famous Escher lithograph. And this shows Hillary trying to follow a map out of the intricate web of health insurance and not being able to find the way out. The Clinton plan implodes. Nothing of any significance comes from it. And what we have in the later 1990s is just a couple of more patches on the American patchwork system, as you can see in the next slide. People debating over which patches to put on the US healthcare system and neglecting to realize that a growing number at that point, 40 million people, are uninsured, and therefore there is a major systemic problem which was not being addressed by the piecemeal measures. Cartoonists pick up the cudgels and I think very successfully start identifying some of the major problems that, of course, PNHP is very vigorously identifying and advocating. This cartoonist in the next slide captures a major problem that PNHP identifies. Do we see a problem, doctor? Yes, there's an insurance company intermediary between the doctor and the patient. And that is not only inefficient, it is also very deflective of any real advance and progress in the American healthcare system. An even more vivid cartoon is the next one, which quite appropriately portrays the health insurance industry as leeches. So the clever remark here is leeches haven't been abandoned entirely in the medical system, perhaps not as therapy as in the old days, but certainly as an integral part of the healthcare system. And by the early 2000s, cartoonists and other commentators are identifying the doublespeak and the self-contradiction and the self-serving language being used by the health insurance industry as captured in this next cartoon, a brilliant Max Worker cartoon, where we have the representative of Healthy Profits, Inc., good name for an insurance company, which is saying, are you nuts? You want the government involved? That would create bureaucracy, that would create socialism, etc. At the same time that behind them you can see Department of Claims denials, Department of Denial of Pre-Existing Conditions, of relentless advertising. That is the huge, vast, profit-serving bureaucracy that is already upon us in the form of the commercial insurance industry. And this is happening at the same time that Michael Moore produces Sicko in 2007, which was a wake-up call to many and very effectively got some of these same messages across. But the political cartoonists were relentless, as you can see in the next cartoon. There you have the health insurance company draining people of their money, while the individual has been conditioned by this language of anti-socialism and all this sort of fear-mongering to say, I don't want the government in my pockets. Well, of course, the private insurance industry is much more effectively and more deeply in his pockets already and draining of his resources. When actual polls are conducted, and I think this is a very important poll, you can see in the next slide, done by CBS News and the New York Times in 2009, a very significant shift has taken place in American popular attitudes. Whereas in 1979, only 40% of the public polled, represented by the orange, were in favor of a government-provided national health insurance policy. By 2009, 30 years later, that number is close to 60%, 59%, a very important shift in actual attitudes, despite what the insurance industry may be telling you. And similarly, those who thought that private enterprise could take care of things well, back in 1979, 48%, that number had declined to 32%. There is a sea change, and it's a very significant one. Quickly moving forward, the 2008-2009 presidential campaign, we have in the next slide, John McCain running against Barack Obama, offering a tired set of old ideas, tax rebates, no major changes, whatever Obama wants, it's too much, it's not going to do. But in fact, what you can see here, there are more leeches here in the form of the insurance industry, big pharma, HMOs, who are taking their bite out of poor Uncle Sam because Is just you are adding new resources in the form of the tax cuts, which no systemic change, no important modification in the way this system works, and that's merely going to feed those industries and those particular leeches. Obama comes up with a very complicated scheme, as we all know, the Affordable Care Act. And in the next cartoon, we have a sense of the difficulties that even that plan ran into. There's Obama in the lower left trying to be professorial and lecture on the bending down of the cost curve. But in the background is a great noise machine, drowning out any attempt at rational discussion, at real debate, and yelling about death panels, but also yelling about socialism and communism and the like, encouraging rage, stoking it up, and really steering people away from any kind of rational discussion. Next slide, another cartoon. When the public option was offered, that was also very carefully assaulted. Their representatives of the health insurance industry are looking out, seeing big signs of socialism. And this is the confuse the public option. They say happily, they know exactly what the dynamic is, how it's working, and why they're very much in favor of it. When the Affordable Care Act is approved, next slide, please, many, especially those in the single-payer movement, see it as a vast compromise and appeasement of the insurance industry. And here is Obama depicted as if he were Neville Chamberlain in 1938 at Munich, saying, we have achieved peace in our time, just as Obama is saying naively, we have achieved health care in our time. But as he's as channeling Neville Chamberlain, and is as disconnected from reality as Chamberlain was then back in the 30s about Hitler's real tactics and objectives. We next move to the so-called town hall meetings. Next slide, please, which many have regarded as astroturf rather than real grassroots expressions of political concern and political will that is funded by the Koch brothers and other large industry sources. And placed in those meetings, of course, is the assault on Obamacare, as you can see, equals communism, no socialist healthcare, and those sorts of messages, again, having political salience because they have a long and sadly effective tradition in the American political environment. It leads to such incredible confusion as this in the next slide, where someone who is saying, I want no part of socialized medicine, Obama socialized medicine, and he better keep his hands off my Medicare too, which is, of course, the ironic confusion. Medicare would be closer to some form of socialized medicine than anything that Obama offered. But this is just the kind of confusion and the insanity that is deliberately manipulated so effectively by the political forces who want to prevent movement towards a national health movement. Just a few slides to finish up. We get to the Republicans starting in 2016 and their repeated attempts to repeal Obamacare, but it's another bit of insanity. Repeal Obamacare shampoo, you work yourself into a lather first, and then you rinse and repeat and repeat and repeat and repeat without success, as it turns out. And the Republicans also, especially under Trump, next slide, please, tried to push policies which Paul Krugman has appropriately labeled zombie policies, that the ideas are dead, but they continue to live and they're very hard to put down, such as the advantage of tax cuts for the wealthy, which would then trickle down and benefit everyone. But in fact, what we have are zombies eating our brains without any advance of proper social policy, as this cartoon captures. If we turn to actual trends as the Kaiser Family Foundation has measured in various polls, next slide, please. What you need to see here is that those in favor of the Affordable Care Act, are trying to build on it and improve it, are in the upper bar, and those who are against it, the lower bar. There's a lot of overlap and confusion until about 2017, when the Affordable Care Act its measures were very seriously threatened by the Trump administration and Republicans, and that meant that support began to increase, so that by this last polling date, 53% were in favor of trying to fix or retain the Affordable Care Act rather than do away with it, and 35% were against it. Support is building. And some other polls, we can see a building support to some sort of national program, whether it be a modified Affordable Care Act or more and better. In the next slide, here was a poll that indicated that 57% in 2017 were in favor of public option, 60% in favor of Medicare for all, whereas the opposition was rather small. And in the next slide, it's a little harder to read, but the main thing is it depends what you call it. Terminology is very important. This is a message for political strategy, and I hope this will be taken up in the further conversations during this 3-day forum. If you call whatever you're advancing as a public system, something like universal health insurance or Medicare for all, a very significant percentage of those polled, 63% as opposed to 31%, are in favor as opposed to 31% against it. But if you call it or allow it to be called socialized medicine, that old socialized rhetoric, that labeling, that tarring, that blemishing works effectively as a political stratagem, and support drops down to 46%, just about half and half. And if you call it single payer, I think this is a lesson to be learned here. Only 49% in this Kaiser Family Foundation poll were in favor of it, 32% were opposed, but 19% were unclear, which is the largest unclear or without opinion in this set of polling data, which suggests that a great deal of education has to be done about the single payer terminology and maybe consideration of another terminology. And I'll just leave you with this last slide, and that is, even though you may feel that you're promoting what is absolutely unquestionable, proper, good policy, you've got to be prepared, even if you were Christ himself, to be labeled as a socialist or fascist because you were advocating something as awful as healing the sick and curing the lame. The end of my presentation.
Fantastic, Ted. Thank you so much. It's incredible the way that these leftist terms have been so cynically weaponized and effectively demonized to oppose Medicare for all. I want to quickly remind the audience, if you have any questions for Ted, Anna, or Steffi, please put them in the chat section and we will get to the Q&A session at the end of their presentations here. And with that, I will pass it over to Dr. Anna Malino to give her presentation on how the system currently operates.
Okay, I need to share my screen. I think that's what it is. We'll see. Nope. Okay.
Apologies, everybody. Just bear with us for just a second here.
Yeah. Do I have screen sharing options?
Andy, can we make sure that she does have screen sharing there? While we get this figured out, I actually have a quick question for Ted that we can maybe do in the meantime. I'm curious how you think that you mentioned the important role that the labor movement has played in pushing for single payer. And I'm just curious, I know most labor unions, or at least a lot of them, do support single payer, but I have seen some labor unions come out in opposition. I was just curious if you could give a brief, how do you think they get co-opted, or why do you think they take that position?
Well, I think it's a very complicated question. I'd like to really hear Anna and Steffi on this as well. But the labor movement is not by any means uniform. There are some unions which have strongly supported single payer for a long time, and others who would rather protect what they have now. There's always the fear of losing what you have if you go for something new. And they feel if their membership is sufficiently well covered by employment-based insurance, they don't want to risk losing that. And that might also provide some support for their own labor authority. I think the labor movement is really across the spectrum. There are some very strong advocates for single payer in the labor movement and very strong opponents in the labor movement as well.
Gotcha. And I'll just share a quick anecdote actually along those lines. I volunteered for Bernie in a few different areas in 2020, and one of them was in Las Vegas. I'm forgetting the name of the union that represents a lot of the restaurant workers and casino workers and things on the Strip, but I spoke with someone who had worked with that union, and they expressed to me that I wouldn't believe how much resource and capital and leverage and things go towards negotiating that good healthcare plan, and how much they could improve their workers' compensation and workplace treatment in other areas if they had those resources to apply to those areas instead. Are we set to go here?
Can you see my screen?
There we
Yes.
go. You're all ready to go. All right. Without further ado,
All right.
Dr. Anna Manilow.
All right. Thank you, Luke. It's a pleasure to be here today to explain our broken system of no system, 100 years of putting this system together piece by piece. Nothing exemplifies our healthcare system better than this cartoon of how single payer was scrapped by Obamacare to become the world's most complicated healthcare system, unless we were to choose the simpler GOP plan, which is simply to get sick and die. As someone once said, a system is perfectly designed to get exactly the results it gets, and our broken, complicated system of no system gets results. We're going to spend the next 30 minutes or so trying to understand the system of no system. First, we're going to look at the big picture, the US healthcare pie, which, as we will see, is messy and stable and varies state by state, but for a few exceptions, is profit-driven. Next, we will take the system apart and look at the individual pieces made up of employer-sponsored health insurance, the individual market, Medicaid, Medicare, and military programs, and sprinkle throughout the Affordable Care Act, also known as the ACA. For every slice, we will have a quiz. And finally, I will challenge you to imagine principles for a healthcare system that is all right, and to keep this in mind as you learn about our broken healthcare system in the next few days. So I like to think of the US healthcare system like a pie cut into slices where we all spend some time in. The first piece, shown here in blue, is the biggest, and where the employer provides private health insurance for their workers and covers about 50% of us. The next piece, shown in orange, is the non-group market, where individuals or individual families purchase private health insurance on their own without the help of an employer. This covers about 5% of us. The next piece, shown in green, is Medicaid, one of our so-called public programs that covers about 18% of us. And the following piece, shown in gold, is Medicare, another one of our quasi-public programs, and this piece covers 16% of us. The dark green represents the military, mostly made up by the Veterans Administration, the most public of our programs, although threatened as well, and it covers 2% of Americans. And that brings us to the last piece, shown in red, the uninsured. I know that I can't see you all, I'm just looking at my screen, but wherever you are, raise your hand if you've ever been uninsured, or if a family member has ever been uninsured, or if a work colleague, neighbor, or friend has ever been uninsured. I'm raising my hand because I was uninsured as a young adult. All my children have been uninsured at some point in time. My guess is that many, many of you are raising your hand right now. So one thing about this
and
pie
I hate
is
to
that
interrupt. I just don't want it to get in the way of your presentation there. Can you hide the bar at the bottom of the screen? I just would hate for any slide to be interrupted there.
Oh, I'm so sorry. Oh, you're right. You
No,
told
no
me
problem.
to do that before.
No problem.
Thank you. Thank you.
Yeah.
So, all right, moving on. So this pie looks static, but the truth is that most of us spend our time slipping from piece to piece until we finally happily land on that golden piece of Medicare. Now, before you get too comfortable, I must tell you that every state is different. So there are 50 pies. The Texas pie on the left, you see that the blue employer piece is smaller. The green piece of Medicaid is smaller, which makes the red piece, you see this is just simple geometry, bigger. Now compare this to Massachusetts on the right, where the blue employer piece is quite a bit bigger. The green Medicaid piece is bigger, which makes the red piece, by simple geometry, smaller. Now, the Affordable Care Act, signed by President Obama in 2010, tried to turn every state into Massachusetts. Now, they tried to make the blue piece bigger by using employer mandates, to make the brown piece bigger by enforcing individual mandates that have since been repealed by Trump, and to make the green piece bigger by expanding Medicaid. All this should shrink the size of the red piece, right? The number of uninsured, into a state like Massachusetts. Good geometry, just not good health policy, because we are all still stuck with this pie. So let's spend some time with each piece asking, and I hope answering, some questions. This is the blue piece called employer-sponsored health insurance that covers about 164 million individuals in the US. By the way, all the slides have references, so even if it sounds like I'm making stuff up, I'm not. The questions are, how much does this insurance cost employers and workers? Is it affordable to the worker? Have costs gone up? If you work, do you get health insurance? And what is underinsurance and how many people have that? So to answer the question of how much it costs, we go to an index called the Millman Medical Index, which publishes a report every year on the total cost of purchasing a PPO, which is the most common health plan, for an average family of 4, including premiums and out-of-pocket costs, and the cost for the employer. And in 2021, you see that the cost of the average family was a little over $12,000, and the cost for the employer was a little over $16,000. So the total for the year is $28,300. So remember, however, that this that's over $28,000 that's coming out of the worker's paycheck every year. But what does this mean to a worker to pay $12,200 for private health insurance every year? Well, it depends on the family. For starting at the top, for a white family living in DC, the richest area in the country, paying $12,000 means 9% of their income. For the median household in the US, $12,000 is 18% of their income. For the median household income in Mississippi, the poorest state in the country, paying $12,000 for health insurance means 63% of their yearly income. And for someone working for minimum wage, paying $12,000 for health insurance means 77% of their income. Something they couldn't do. So you start to understand how employer-sponsored health insurance can be affordable to some and completely unaffordable to others, even if the employer offers it. Now, to answer the question, have costs gone up, we will look at the cumulative increases from 1999 in 4 different domains. You can see inflation, wages, family premiums, and the worker contributions to that premium. And so starting from the bottom, you can see that since 1999, inflation, which is pictured here in the black line at the bottom, has increased cumulatively since 1999, 47%. Wages, pictured here in the green, have just kept up with inflation and have increased 64%. But in the same period, family premiums, pictured in the blue, have increased 224%, and the worker contribution to that premium in the red has increased a whopping 270%. And this is the reason wages haven't increased. So yes, costs have gone up, even since the passage of the Affordable Care Act in 2010, there shown in the dotted line. So does every worker who works have employer-sponsored health insurance? So this slide is going a little too fast, but we're going to get there. So let's look at the blue bars first, which represent employer insurance for the total population on the left, then to the right, the white population, black population, and then Latinx workers. You can see that almost 60% of all workers have employer insurance, about 65% of white workers have employer insurance, and fewer than 50% of black workers and about 40% of Latinx workers have employer-sponsored health insurance. And it's not because they're not working, because if you look at the mustard bars, that's the percent of the population in the workforce, men, women, and young adults. And you can see that in the total population, more workers work than they get employer insurance. Among white workers, most workers are covered by employer insurance, but fewer black workers and even fewer Latinx workers have employer insurance, despite the fact that Latinx is the community that works the most. They're working all right, they're just not getting health insurance. And for those who do work and have employer insurance, the pandemic uncovered just how tenuous this relationship is, when job losses resulted in millions of individuals losing their own health insurance and that of their dependents. So what is underinsurance and how many people does it affect? Well, underinsurance is defined as spending more than 10% of your income on out-of-pocket health costs. So not your premiums, that doesn't even enter into it, just your out-of-pocket costs. And here we're only going to look at non-elderly individuals because, as we will see, most elderly are covered. So say we're in a room with 100 people. I don't know how many people are here today, but say we're in the room with 100 people. 55 will be insured all year. 23 will be insured, but be underinsured. 10 will have insurance with gaps throughout the year, and 12 will be uninsured. This means that 45 people in our room of 100, or 45% of the people in the US, are underinsured or uninsured. So we should be able to answer our quiz questions now. And that is, We know that it costs about $16,000 per year for employers and $12,000 per year for workers. Well, it's not really affordable to the average worker. Costs have gone up about 270% for families since 1999. If you work, are you automatically covered? Absolutely not. Latinx individuals are much more likely to work than whites, yet are 3 times more likely to be uninsured. And we now know that about 45% of people in the US are uninsured or underinsured. So moving to the next piece of the pie, we land on the non-group market, where individuals purchase their own health insurance, and it covers about 18 million individuals. Our questions include, what is the marketplace, also known as the exchanges? How do you qualify? And finally, how much does this cost? Now, after the passage of the Affordable Care Act with the individual mandate, it became clear that you could not mandate someone to pay 77, 63, or even 18% of their salary on health insurance. So to make health insurance more affordable, everyone would still be mandated to have private health insurance with help from government subsidies that differed according to your income, with the poor getting more subsidies than the non-poor, subsidies that went straight to the insurance companies, making them billions of dollars richer. And we know what they do with their money. No, not to improve care, but to pay for their own exorbitant salaries and buy members of Congress to vote against single payer. But I get ahead of myself. Now, to purchase these policies, you must go to a website that has 1,700 state rules to determine eligibility and how much you need to pay according to the level of coverage you choose, because you can choose the different, silver, bronze, so forth. Now, the first cartoon we saw was not an exaggeration. What I'm showing you on the right is not a cartoon, it's for real. So how does this work? Well, there is this handy calculator from the Kaiser Family Foundation website where you can plug in your state, and I just put in the US average, how much money you make, and I put in 67,500, which is the median household income in the US. And I also added that this was a family of 4 with 2 young parents and 2 young children, none of whom smoke. I hit submit, and presto, you are told that your family earns 258% of the federal poverty level, and that you will get $1,159 in financial help, which goes straight to the insurance company, and you will only pay $242 per month, which should be only 4.31% of your annual income. But what they put in very, very, very small print is that you're in network. Okay, we're talking about in network, out of pocket max, meaning if you actually use healthcare that year, will be $17,000, which is really 25% of your income. So, answers to our questions. The marketplace was created by the Affordable Care Act to let people enroll for private health insurance with government subsidies. You qualify based on your income, your age, your gender, your family composition, and your geographic location. It's affordable maybe until you need health care. So moving on, we find ourselves like 83.6 million people in Medicaid. A small asterisk reminds me to mention that there has been an increase of over 12 million people since the start of the pandemic due to the Families First Act, which banned states from involuntarily disenrolling beneficiaries during the public health emergency. Yeah, because that happens. This will become clear in a minute. So our questions are, who qualifies for Medicaid? What is the federal poverty level? Can you lose Medicaid? Has it reduced the uninsured as proposed by the Affordable Care Act? What is CHIP? And what about children? So Medicaid is a federally and state-funded program administered by each state, which makes eligibility and benefits vary widely from state to state. It is means tested, which means that you have to prove your poverty, and depends on the family's monthly income, which can vary month to month, as many people on Medicaid do. As I mentioned, the Families First Act banned this type of disenrolling, but once the public health emergency is declared over, which is going to be very soon, up to 15 million individuals, including 6 million children, are at risk for losing their Medicaid. While we think of Medicaid as being public, the truth is that up to 70% of all Medicaid beneficiaries are managed by private health insurance companies. Now, let's see what it takes to qualify for Medicaid. Now, remember, every state is different, and we will look at Texas, not because it's the worst state, but because it is a state that has not expanded Medicaid. So let's look first at the dark green bars, which represent people on Medicaid. It starts with your monthly income according to 100% of the federal poverty level, shown here by the red dashed line, which in 2021 for a family of 4 was $26,500 per year. Now, if you look at the x-axis, that's the horizontal axis, you can also see it depends if you're a child, and if you're a child on your age, if you're pregnant, if you're an adult with children or without, if you're on SSI, and if you're over 65 for long-term care. Now, let's take a look at the green bars. In Texas, if you have a child under the age of 1 and your family makes under $4,500 per month, your child will qualify for Medicaid. But the day your child turns 1 to 5, the family must make under $3,300 per month for the child to qualify. And once your child turns 6 to 18, the family must make under $3,000 for your child to qualify. Mind you, a family can have 3 children, all different ages, all different monthly income requirements. Now, moving on, if you are pregnant, your family of 4 must make under $4,500 for you as a pregnant woman to qualify for Medicaid. And if you're an adult with children, you must make under $375 per month. You heard me, $375 per month to qualify for Medicaid. Now, in states that did expand Medicaid, adults can make up to $3,000 per month to qualify, but not in Texas and not in the 11 other states which have not yet expanded Medicaid. So if you're an adult moving on without children in Texas, you do not qualify for Medicaid. If you're on SSI, you can make up to $1,600 per month to qualify. And if you're over 65 and you make under $2,500 per month, Medicaid will pay for your long-term care, but you must give every penny to Medicaid except that they let you keep about $40 a month. Now, CHIP, or the Children's Health Insurance Program, was passed to cover those children whose parents made it too much for Medicaid and not enough to pay for private insurance. Every state is different, but in Texas, as you can see in the light green bars, it covers all children through 18 whose parents make 200% of the federal poverty level or less. As you can imagine, except during a pandemic, there's plenty of churning, which means coming in and out of Medicaid because you make slightly more money one month compared to another. About 55% of pregnant women lose their Medicaid within 6 months after giving birth because in most states, eligibility ends 60 days after giving birth, and many of them no longer qualify as adults. So, to answer the question, did the expansion of Medicaid reduce the number of uninsured? We will compare 2 states. West Virginia, a poor state, which expanded Medicaid, and Texas, not such a poor state, which did not. Now, the blue bars represent the percent of people covered by employer insurance. You can see that fewer people are covered by their employees in West Virginia compared to Texas slightly, but because many more people in West Virginia are covered by Medicaid, those are the green bars, compared to Texas, fewer people are uninsured in the red bars than they are in Texas. So these are the 12 holdout, mostly southern states that have not expanded Medicaid. This is what happens when you allow states to decide health policy. Now, what about children? About 40% of children in the US are covered by Medicaid. Here, we look at the insurance coverage for white, Latinx, and Black children, and the blue bars represent children covered by their parents' employers, and you can see the difference between white, Latinx, and Black children, just like their parents. Shouldn't be a surprise. The green bars represent Medicaid, and you can see the difference between white, Latinx, and Black coverage for children, and as a result, few white children are uninsured. Those are the red bars. But more Latinx children are uninsured, and Black children, because they qualify for more Medicaid, have fewer uninsured. And overall, about 5% of children are uninsured. So to answer our questions, our quiz questions, we learned that qualifying for Medicaid depends on your age, if you're pregnant, your state, your disability, and income. The federal poverty level for a family of 4 is $26,500. You can lose it because it's month to month. Does it reduce the uninsured? Yes, it has in those states that have expanded Medicaid. And CHIP is the insurance program for children whose parents make too much to qualify for Medicaid and not enough to pay for private health insurance. And children's access to care is tiered and racially segregated. Now we're on to Medicare, where 57 million people get their health coverage. Our questions are, what percent of seniors are covered? And when do you qualify? And is it simple? And does it cover all your healthcare costs? Well, if President Obama, when he was designing the Affordable Care Act, really wanted to lower the number of uninsured to 0, he could have looked at this graph from the US Census that shows us the percentage of people without health insurance before and after the ACA. Remember, the Affordable Care Act was passed in 2010, but fully implemented in 2014. So the percent of uninsured among non-elderly adults in the blue line did go down, as did the percentage of children without health insurance in the middle line. But for seniors, it stayed pretty much at zero. The way to cover everyone is to expand Medicare to everyone. Medicare, as most of you know, and especially after Ted's talk, was passed in 1965 to cover the elderly. It is our one single-payer system, which is publicly funded through payroll taxes and general revenue, and it is privately delivered. It is automatic for people when they turn 65 and covers individuals also with renal disease, ALS, and some people with disabilities. It is not simple. Surprise. My brother, as an aside, has an MD PhD, and today he told me that he just turned 65 and told me that he needed to get a Medicare PhD because he can't figure it out. So half of seniors choose to stay on traditional fee-for-service Medicare with 2% administrative costs, and this is at risk for being privatized. And the other half choose Medicare Advantage, private insurance companies to manage their care, costs more than traditional Medicare and has higher administrative costs, and already is fully privatized. Now, let's look at traditional original fee-for-service Medicare. There is Part A to cover hospital costs, Part B that covers 80% of outpatient costs, and Part D that covers prescription drug costs. Each part has premiums and deductibles. Most seniors purchase a private supplemental plan to cover the uncovered 20% costs, and still Medicare only covers 2/3 of all healthcare costs, has out-of-pocket costs for seniors, and does not cover hearing, vision, dental, or long-term care. So this is not the kind of Medicare for all we're talking about. So our quiz answers. We see that almost all seniors are covered by Medicare when they turn 65. It is not simple, and it covers only 2/3 of all healthcare costs for seniors. Now, almost all public program in the US is the Veterans Health Administration, which covers 9 million veterans. It is fully integrated, mission-driven, rather than profit-driven system. It is the only socialized system, ironically, where all providers are salaries. It is fully integrated. It covers all necessary medical care and is quite comprehensive, covering prescription drugs and long-term care as well. There are eligibility criteria for vets, which unfortunately exclude more than half of all vets, but it is free at the point of care with minimal copays for certain vets. And just like every other program, every other public program, it is facing serious efforts to privatize the entire system. And we finally arrive at the piece of the uninsured, which covers almost 10% or 30 million of us. In addition to asking how many are uninsured, we also ask who are the uninsured, although many of us have already been uninsured or are uninsured, and what are the consequences of being uninsured. This graph shows the uninsured by race and ethnicity over time from 2010, before the implementation of the Affordable Care Act, to 2018, after the full implementation of the ACA. And you can see that while the Affordable Care Act did result in a decrease of the uninsured, there are still 30 million uninsured. The decrease was not equal between races and ethnicities, and certainly not zero. Now, as you can see from this bar graph, from the US Census on the right, anyone can be uninsured. I know it's sort of small, but I'll just tell you what I can see, especially Latinx, non-citizens, all workers. What we know is essential workers, which are in that box on the left. If you are separated, if you live in the South, or in a state that has not expanded Medicaid. So most people who are uninsured work, as you can see in the pie graph on the left. 75% have one or more full-time workers in their family. Most are poor. They live under 100% of the federal poverty level, and most are white or Latinx. Now, while being uninsured decreases your chances of visiting a doctor or paying for prescription drugs, it can have fatal consequences. The flu season of 2019 to 2020, and that was the year before the pandemic, 20,000 people died from the flu. That year and every year, 35,000 people die from being uninsured. So our quiz answers: How many are uninsured? About 30 million people are uninsured. We know that people from all walks of life can be uninsured, particularly workers, mostly poor, all races, but especially white and Latinx. And the consequences of being uninsured in the US is dying unnecessarily. So, next question is, how much does this pie cost? How do we compare to other countries? Is our healthcare system equitable? Are we getting our money's worth? And who profits? Well, compared to high-income countries, such as the UK, Japan, Canada, Germany, and Switzerland, as you can see here, we outspend every other country except Switzerland by twice as much. We still outspend Switzerland, but not by twice as much. Now, spending $12,500 per person per year adds up to $4.1 trillion spent on healthcare in 1 year. To give you a scope of 4.1 trillion, there are 3.1 trillion seconds in 100,000 years. You could spend $1 every second for the next 100,000 years, and you'd still not spend $4.1 trillion. Now, why do we spend this much? Well, compared to other high-income countries, we are younger. We don't smoke as much. We don't drink more, but yes, we are more obese, but many other countries have obesity as well. So it's not because we have more risk factors that our healthcare costs are high. And despite outspending every other nation and not having more risk factors, compared to other countries, the US has, the lowest percentage of people covered, the lowest life expectancy, and worst maternal, infant, and neonatal mortality. In comparison, we have equal health force, same number of hospital beds, and equal rates of utilization, but we do have significantly greater administrative costs, spend lots more on prescription drugs because the government doesn't negotiate with pharmaceutical companies, and our prices are much, much higher. Compared to other high-income countries, shown here, the US has had the greatest number of deaths from COVID per million people. You can see there the latest wave, the United States on top. And we know this has affected communities of color unequally. The risk of hospitalization from COVID has been 2.4 times greater among Latinx communities and 2.5 times greater among Black communities compared to white. And the risk of death from COVID is almost 2 times greater among Latinx communities and 1.7 times greater among Black communities. And why? Because we have a system of no system based on profit. This is an article from the New York Times early on in the pandemic. It was August of 2020, when rural hospitals were struggling, small physician practices were folding, and healthcare workers were being furloughed. And all the while, hospital chains and insurance companies were making record profits from taxpayer dollars. And the combined pre-tax profits of vaccine makers Pfizer, BioNTech, and Moderna will be over $1,000 per second. So, to answer our quiz, 2 years ago, we spent $4.1 trillion on healthcare, twice the average of most high-income countries. We are not getting our money's worth, and corporations and not patients are profiting. Now, imagine you and a group of your best friends were given $4.1 trillion to design a healthcare system worth $4.1 trillion. What would be your non-negotiable guiding principles? My guess is that healthy profits would not be one of them. So I've given this talk a bit, and I usually ask my audience to come up with a list of 5 to 6 guiding principles. And after giving this talk for over 100 times, every time everyone comes up with the same list: universal, comprehensive, sustainable, accessible, and free at the point of care, gender affirming, high quality and evidence-based, and equitable. It shows me that we all agree on what we want. Now we just have to agree on how to get there. And this is how we get there, with National Single Payer Health, or National Single Payer Health Program, because everyone has the right to health care. Now that you hopefully understand our broken healthcare system, how all the pieces fit together, how it is expensive because it's based on profit, we can fight for the system we deserve. Healthcare is a human right, and healthcare should be for people, not for profit. I invite you to come up with your own list of non-negotiable guiding principles and think about these principles as we participate in the summit. I'll be referring to these again as we wrap up on Sunday. I would like to finish with thanking all the patients who, over 30 years, have given me the inspiration to fight for single payer, the mentors who gave me the tools to fight, and the activists who have helped me along the way. So I will hand it over to Dr. Steffi Woolhandler, who has been one of the wonderful mentors who has given me the tools to fight. Thank you, everyone.
And if I could just cut in really quick, just one more time, I want to remind the audience to put questions in the chat if you have any questions for our wonderful panelists today. And Dr. Woolhandler is going to go over the harms from privatization. So here's Steffi Woolhandler on her presentation.
Yeah, hi, Andy. Can I have? Oh, great. Okay, I'm going to be talking about the pitfalls of privatization. And it's a bit the question about would Medicare Advantage, that is private insurance for all, be just as good as a real single payer Medicare for all program? Next slide. Now, already our taxes are funding about 2/3 of health spending. So Anna was showing where people got their coverage, and it looks like the government piece is small, but that's not really true because when you look not at people who have these different insurances, but where the money comes from, you get a pie that looks like this, where you have Medicare, which is taxpayer funded, Medicaid, VA, public health in white, government worker benefits. I now work for the city and state of New York. They pay benefits for me out of tax dollars. The so-called tax subsidy to private insurance. It turns out that at the funding level, the majority of the funding for the healthcare system already comes from public payers. Next slide. This relates to the fact that private health insurance, by which I mean privately purchased, privately funded health insurance from private insurers, that has actually shrunken, used to cover over 80% of the population, and currently private sector private coverage is really only about 65% of the population covered at most. Next slide. It turns so how come private insurers have so much money, and they're getting bigger and stronger if there's a shrinkage of like commercial private insurance? Well, it turns out the government turns over a huge share of taxpayer dollars to private insurers for health care. A bunch of the money for private insurers comes in that bright yellow slice from private employers and private households. But a chunk of it also comes from city and state of New York, who pays for benefits for me, or federal government and state and local governments that purchase health benefits for their workers with public dollars. And there's Medicare, which is most funneled through private insurance through the so-called Medicare Advantage program, and managed care Medicaid money that's turned over to private insurance companies to run the health plan. Next slide. So what we're coming to is a corporate-run managed care system that is going to replace both fee-for-service care and nonprofit managed care. So we have privatization, which is really corporatization, moved to a private profit-oriented system, largely structured around managed care. Next slide. Now, some of you, I think, are probably in Southern California. You're probably not thinking about where your water comes from, but it turns out the water you're drinking actually comes from a long way away. The Hoover Dam out in the mountains. It goes through Arizona, all the way across the country. And next slide. And this is what the Hoover Dam actually looks like. It's out in the middle of the freaking desert, right? Next slide. Now, it was built on a government contract by Kaiser Steel that had a bunch of workers out there in the middle of the desert, including building that giant aqueduct that goes all the way from Arizona to Los Angeles. Next slide. And there was a problem with this, which there were workers out in the middle of the desert. There was no health care. So Kaiser Steel put together a plan to put clinics and hospitals out there in the desert for the people working on the Hoover Dam. So that's the origins of managed care in this country, the origins of Kaiser. But when I mean out in the desert, I mean it. Next slide. This is actually Desert Center, California, this was physically the site of the first Kaiser hospital. Obviously, there's nothing there now, and there was nothing there before the hospital, and there's nothing there now. So this was a model of managed care, not that it was going to make profits in its own right. It didn't make profits. It was all nonprofit, right? But it was going to assist Kaiser Steel in making profits by providing health care for the workers. Next slide. And that model, next slide, please. That model of managed care stuck around until um, in the 1970s. A man named Paul Elwood put together the idea that an HMO, managed care, could be a profit making entity in its own right, not just something to serve other profit making. But the HMO would agree to provide comprehensive health maintenance services to its enrollees in exchange for a fixed annual fee. The economic incentives of both the provider and the consumer would be aligned, and you could actually make money off of an HMO in its own right. Next slide. Now, this was put in place and advocated over the years despite substantial and relatively early evidence that high risk people do not do very well in the HMO setting. And these are the results from the Rand health insurance experiment that was done in the 70s with $100 million of federal tax money, where people were randomly assigned to HMOs versus fee for service care. And among people with even minor health problems like high blood pressure, um, those in the HMO had an elevated risk of dying, represented in this slide by the 1.21. That's a 21% increase risk of dying relative to people in a free fee for service system. It turned out it was because their blood pressure was poorly controlled. But we did know very early on that if you have a medical condition, it's not a great idea to be in the managed care setting. Next slide. And this is particularly true in another study, the medical outcome study that looked at mentally ill people. That I'm not going to go through the slide, but it'll be available to you. But it turns out if you're depressed or mentally ill, you're much better off in a free fee for service system than you are in a managed care system where they're trying to save money by not giving you care. Next slide. And this is an audit that was done. It's a federal audit, again, looking at managed mental health care, which was really outrageously bad for mentally ill people. The managed mental health plans overstated how much care they gave. They delayed referrals for mental health services. They'd enroll people and then have no mental health providers in 15% of the counties where they enrolled people. Again, this is known. This is not some secret that the managed care was doing a very poor job with people with expensive medical needs. The managed care was maybe okay if you were healthy, but if you really had medical needs, there was good evidence that it was going to fail. Next slide. And this was kind of summarized in this, rather cynical cartoon. Your HMO is paying me big bucks to hold down your treatment costs. You want to make me a better offer. Next slide. So doctors were pulled into this. Again, despite the doctors saying they knew that capitation was cutting their use of needed services. This is actually uh, doctors being asked with vignettes about, does the patient need the service? Would you give them the service if they had regular medical care fee for service? Would you give it to them if they had capitation? The doctors knew that the capitation was cutting care that people needed. Next slide. And similarly, when he asked doctors, do you think capitation, paying a set fee and running managed care, is that ethical? Really, a very high proportion of doctors will say it's a conflict. Being capitation is a conflict of interest. It's unethical. Many of them also feel it was unavoidable and probably, unless we change the system to a single payer, will continue to be unavoidable. Next slide. Now, it turns out that most managed care currently is kind of a hybrid. It kind of semi looks like fee for service, but it really is managed care. So the doctor might get some payment for seeing the patient, but in order to get their bonuses that bring their salary up to par, they're going to have to manage the care and cut back on the care. Next slide. And this is actually material from my own contract that I had with U.S. Healthcare. It actually became Aetna, and now it's CVS Aetna, but at the time it was called U.S. Healthcare, and I had a contract, and it said that my income as a primary care doctor would be based on um, the number of hospital days my patients had, the number of specialty referrals where I'd get more money if they had less referrals, number of ER visits, I'd get more money if I didn't let them go to the ER, and some certain quality and loyalty measures. And based, if I didn't get any of the bonuses, if I just ignored the managed care aspects, I would earn about $123,000 a year, which sounds good until you realize that's the cost of my overhead to run a practice, about $123,000 a year. So really, in order to make any salary for myself, I would have to make the bonuses. I would have to participate and in the managed care elements and cut back on my patients' use of hospital days, specialty referrals, and ED visits. Next slide. Well, my partner, David Himmelstein, was also one on in the U.S. healthcare, and he published the contract provisions along with me in the New England Journal of Medicine, saying we thought it was unethical. And he got this letter saying that he was fired from U.S. healthcare and he couldn't practice there anymore. And actually, there was a bit of an outcry about it. Next slide. And it ended up being in Time magazine. This is not a picture of my partner, but they found like a model or something. But there was a scandal about doctors being gagged and told they couldn't share the conditions of their contract, even when those conditions might hurt patients. And actually, he was rehired. Next slide. But unfortunately, HMO retribution to doctors for providing high cost care did not end. And Aetna Health Plans did name this gentleman, I know his name, but it's his initials. He was named Primary Care Physician of the Month 1 month. And then, literally 2 months later, they fired him because he exceeded the guidelines for cost per patient. He was too expensive. Next slide. Okay. So Medicare HMOs, like HMOs kind of got a bad name and people don't use that a whole lot anymore. So Medicare HMOs, which are private plans that provide managed care to Medicare enrollees, have been rebranded as Medicare Advantage, but I'm going to use those terms interchangeably. Next slide. And there has just been this tremendous growth in Medicare HMOs or Medicare Advantage. Remember, this is all taxpayer funded. This is our taxes paying for this. And they've just exploded. And they're expected to actually, unless we do something about it, to fully take over the Medicare market over the next 5 years or so. Next slide. Now, this is really remarkable because if we look at the efficiency of traditional Medicare on the left, in terms of how much money is spent for medical care and how much goes to overhead, traditional Medicare only has an overhead of 2%. Medicare Advantage, on the other hand, has an overhead of 6 times that much, about 14%. So you would think that traditional Medicare ought to be able to outcompete Medicare Advantage in the marketplace. Next slide. And just again illustrating this got even worse during the pandemic, where Medicare Advantage during the pandemic was collecting overhead for every senior they enrolled. They were collecting overhead of $2,200, almost $2,300. So something like 20% of everything Medicare spent on private Medicare Advantage plans ended up in the pockets of private insurers. That's the middle set of bars. Okay, next slide. But as I said, despite traditional Medicare's lower overhead, Medicare Advantage plans outcompete traditional Medicare, and they do that. Misspelled and had some typos here, by gaming the payment rules. They learn the payment rules, they game the system, and they adapt very quickly when the payment rules change. They also game the system by cherry picking, upcoding, lobbying, and overpayment. I'm just going to briefly go over what all that means. Next slide. Well, the main thing it means is you become good at cheating and you never need to become good at anything else. That's a Banksy quote. Next slide. Okay. Well, managed care has really moved from its exclusive focus on restricting care as its only profit making strategy to cherry picking and lemon dropping. And I think you probably know what cherry picking means. Next slide. Picking the most profitable patients and getting rid, but you may not know what lemon dropping means, which means getting rid of the ones who are costly. But to explain this briefly, it turns out that healthcare spending is very lopsided, with 20% of all private insurance enrollees spending 80% of the money that private insurance spends. What we're saying is that the 20% of people who are sickest in any given year are consuming most of the medical care. And that's probably true of you if you've ever been hospitalized. You were hospitalized, used a lot of medical care. Most other years of your life, you don't consume much. But it turns out that if you're an insurance company and you're able to selectively recruit those people who are sickest, deciles 9 and 10, who use the most healthcare, uh, you selectively able to recruit people who are not the sickest, everyone below that, deciles 1 through 8, and selectively drop people in deciles 9 and 10, you can actually make a lot of money. So cherry picking means picking the low cost people, lemon dropping means getting rid of those high cost people. Next slide. Okay, so Medicare Advantage programs, HMOs, have been very effective in doing this. So if you graph the average Medicare spending um, in yellow on the left, which is the basis of the payment to Medicare Advantage, average Medicare spending, it turns out that the people who Medicare HMOs enroll had lower costs the year before during joining the HMO. So the HMO cherry picked enrollment got lower cost people. Yet in the 3 months after leaving an HMO, Medicare HMO, and coming back to traditional Medicare, the spending was nearly twice as high as the average for Medicare. Lemon dropping, cherry picking, and lemon dropping. And this is an older study in New England Journal, but next slide. It's still going on today. Even with risk adjustment, the HMOs are able to game the risk adjustment system and cherry pick people within any given diagnoses who are not as sick as other people. So they can cherry pick someone with very mild diabetes, call them diabetic, and avoid someone with very severe diabetes. Next slide. And we see very clear evidence of lemon dropping when we look at the disenrollment, people who are forced out of Medicare Advantage, low needs patients stay in Medicare Advantage, high needs patients are forced out. Next slide. How would you do this? Well, what the Medicare Advantage plans have all started doing is making you pay something called co-insurance if you have chemotherapy. Co-insurance means you as the patient pay a share of the total cost, not $5, not $20, but some percentage of the total cost. And with many chemotherapies, new chemotherapies costing hundreds of thousands of dollars per year, if you force people to take a 20% co-insurance, they're out of pocket a very, very large amount of money. And those people will leave your Medicare Advantage plans if they can to try to find a way where their cancer chemotherapy is more affordable. So you can use benefit design, structure the co-payments, deductibles, and co-insurance in order to make it extremely difficult for people with high cost illnesses to stay in your HMO. Next slide. Okay, so managed care has, just to the other point, they've moved from primary care restriction to other mechanisms. I talked about cherry picking and lemon dropping, but they've also moved to aggressive use of overcoding and overdiagnosis. Next slide. All right. Now, why does a Medicare managed care so much about overcoding and overdiagnosis? And these are a list of diagnoses that apply to the same patient. It's one patient here, but there's two ways of coding it. If you say this person has diabetes mellitus, chronic kidney disease, obesity, depression, chronic uh, coronary artery disease, you only get $5,000. Okay. If you describe the same patient with slightly different words, say they have diabetes mellitus type 2 with diabetic chronic kidney disease. They have chronic kidney disease stage 4. They have morbid obesity rather than just obesity, major depression rather than depression, coronary artery disease with angina rather than chronic coronary artery disease. The same patient described with a different set of words, and now you get a payment like an annual premium from the taxpayers for this patient of 17,000, more than 17,000. So upcoding, sometimes upcoding, but overcoding is immensely profitable. Next slide. And when a patient joins a Medicare HMO, the risk score, the number of diagnoses reported, is that blue line, and it just starts to soar. Lots of things are listed as diagnoses that were either unimportant or listed in slightly different language before, but that causes the cost to the taxpayers to soar. Next slide. Okay. Um, Now, you may be sitting there going, well, this doesn't quite make sense because don't we have these medical loss ratio rules about, how much money the Aetna, for instance, can make? Why would they keep upcoding and upcoding? Well, it turns out the emerging model right now is I call the CVS Aetna model. CVS is actually merged with an insurance company, and now the insurance company essentially owns the doctors. So there are no longer any medical loss ratio rules because you can just mush the extra money into your doctor, a subsidiary. And next slide. This is being done by a lot of other insurers. United Healthcare is does something that they have a special name when they mush the money from the insurance part to the doctor part. It's called an intercorporate transfer, but it's just gone up and up and up over the years as a way of getting around the medical loss ratio rules that were put in place with the ACO. Next slide. Okay. Now, Medicare Advantage plans sometimes just claim diagnoses that they don't even mention in the chart. This is a CMS audit, a federal audit showing literally billions of dollars paid out by the taxpayers for diagnoses that the Medicare HMO reported to CMS in order to get this high premium and then never even wrote down in the chart. Next slide. Okay, now consequently, and this is 20 from old data, this is 10-year-old data, so you have to keep that in mind. But consequently, if we compare the spending, the cost of traditional Medicare versus the cost of Medicare Advantage, the blue part is the part of the premium that actually goes during a month for medical care. And you'll see the traditional Medicare spends more on doctors and nurses and drugs or whatever. But the overhead, the yellow part of the spending is so much higher in the HMOs that the total cost to the taxpayers is actually higher in the Medicare HMO. That is, the taxpayer is spending more for less care, the difference being eaten up as overhead and profit. Next. Okay. Consequently, Medicare Advantage has raised the cost to the taxpayers year upon year upon year. This is from the Medical Policy Advisory Commission of the U.S. Congress. Next. Okay. So what happens with all this overpayment? Well, only a tiny share of the taxpayers' extra payments actually benefit seniors. So if you have a Medicare HMO, you might be able to get free reading glasses, but most of that money, that's an extra benefit. That's good. But most of the money ends up in the pockets of the insurance industry. Next slide. Now, what are accountable care organizations? Well, accountable care organizations are a managed care strategy for turning your local hospital into a managed care organization by creating managed care incentives for them. And Medicare has been leading the charge with this. Next slide. There's been a huge growth, explosive growth of ACOs. Next slide. And the ACOs use the same tactics as other managed care, or many of the same tactics, including lemon dropping of high cost patients. Because of the ways ACOs are paid, it's harder for them to cherry pick, but it's very, very easy for them to lemon drop. And when we look and see, who left the ACO versus who stayed in the ACO, the ones who left were the higher cost patients. They were higher cost by at least $1,000. Next slide. Another slide up. Well, how would you get rid of high cost patients? Well, one way is to fire their doctors. So if you have doctors like I told you, Dr. GS, who was at Aetna, who just happen to have a lot of breast cancer patients or seriously ill patients, you just fire the doctors. And this slide is actually just showing that's exactly what goes on. If a doctor is a high cost doctor, either because they're just profligate or because they have a lot of expensive patients, uh, 30% of them are forced out of the ACO in the course of a year. Next slide. And just despite there's been a lot of hoopla about we're going to save all this money with ACOs, the savings this is data from CMS, from the federal government. At most, $1 billion been saved over 7 years. That's like 140 million, which is less than rounding error in healthcare. It's a $4 trillion business to say, oh, we saved a lot of money. Maybe we saved 140 million a year. It's just that's a ridiculous thing to say. It's really rounding error. Next slide. The latest kid on the block, and Anna Malino's played a big role in publicizing this, are so-called direct contracting entities, and this is likely, if allowed to go unchecked, to fully push Medicare into the hands of private insurance companies. Those what it does is for people who enroll in traditional Medicare who say, I don't want the managed care, it automatically assigns you to direct contracting entity that's paid capitation, similar to a Medicare Advantage plan. Some of these are owned by insurance giants, direct contracting entities. Some are owned by these for-profit startups, like Apple Care, Oak Street Medical, that are collecting huge amounts of money from Wall Street. As with Medicare Advantage, overdiagnosis and upcoding is key to profitability. You can overdiagnose people, raise their risk score, uh, write down a bunch of diagnoses that are not meaningful, raise the risk score even higher, and then get the taxpayers to pay you a big fat premium for someone who's not necessarily all that sick. And consequently, some of the successful some of the successful DCE entities are being valued by Wall Street at as much as $87,000 per enrollee, because the promise of being able to just bilk the taxpayers through these upcoding games is kind of irresistible. Last slide. So to summarize, why does the Medicare for All movement need to focus so much on privatization? I mean, wouldn't it just be great to get everybody some sort of insurance? Well, at some level, yes. But privatization in this way would raise costs to the taxpayers. We know that because that's what's happening in Medicare Advantage. It would restrict the care for the sickest and highest cost patients who need it most, right? It would divert health spending from care to corporate profit, and it would subvert the public accountability and control of healthcare, even the limited amount that we have now, by placing medical care entirely into the hands of corporate entities. Okay, so that's it for me. I guess we have just a few minutes left, but you could.
Thank you so much, Steffi. Fantastic presentation. It's incredible how we hand this system over to people who seem to be more in the business of dodging providing healthcare than they do actually providing it. I do just want to note those last two presentations, we got into some of the funding stuff, and we are going to be talking on Sunday in a panel at 4 Eastern, 1 Pacific about the funding mechanisms and MMT and how the federal government actually goes about funding these federal programs. So make sure not to miss that one if you were interested in a deeper dive into some of the funding that Anna and Steffi were just talking about. We'll go ahead and kick off the Q&A. We have a question from Lee Stanfield. Lee asks, how much of the high cost of U.S. healthcare do the panelists attribute to feed for service, and how much to administrative costs? If any of you want to go ahead and jump in on that one.
Well, I'm going to take that first. You can control costs under fee for service. We know that because many countries with single payer or other forms of good national health programs do have fee for service and are able to control costs through other mechanisms, what we call supply side control. I'm not in love with fee for service. I don't think it's a great system, but that is not the cause of the high cost in the U.S. And the managed care industry would have us believe that there's no way to control costs without corporate care managers in there. That just simply isn't true.
Yeah, the only thing
Fantastic.
that I would add is that when you compare our utilization rate, for example, with other countries, we don't use healthcare more. It's just that it costs more here. So it's if we got rid of fee for service, we would not be controlling costs anymore. In fact, it would even be worse because we're seeing the evidence from Medicare Advantage and managed care that in fact they raise costs rather than control them.
We have one more from Lee Stanfield as well. He asked, Kentuckians for single-payer healthcare want to know, would the public option actually move us forward? I've heard both opinions on this, that it could act as a poison pill for our movement and that it could be, in some micro sense, a step in the right direction. I'm curious what you all might think.
Well, I'm happy to give my opinion. I mean, public option, if you're going to go into the exchange and buy insurance, it would be nice to have another option, right? But it was always seen as just part of the Affordable Care Act. And I think a public option would run into a lot of the same problems competing with private insurance that we've seen in Medicare Advantage competition. If the private insurers are willing to cheat, they're willing to lemon drop and push all of the high-risk patients off into the public option, then your public option just becomes a high-risk pool with very high costs, and it raises the cost of the system. So I'm not opposed to public option, but I don't really think it gets us very close to Medicare for all.
Well,
Ted or Anna, anything to expand on that?
Anna,
I don't know, Ted. No, Ted, go ahead.
I would agree. I think it's just a deflection from what the real political issues are.
Right. It's a little bit of a death spiral. Basically, it's making, right now, the government takes care of the oldest and the sickest and the poorest, right, through Medicare and Medicaid. And having a public option is just going to make the government take care of even more sick patients as well, because that's what's going to happen. The private insurance companies will be lemon dropping and cherry picking the healthy ones. They're really, really good at that. We know that.
Yeah, absolutely. And then I had a question. I can start it off with Ted, because you talked a lot about how the media and some of the cartoonists and things talk about these issues. I'm just curious how you might advise the audience to look out for the kind of propaganda that you were talking about, and how to maybe contradict it. I know a couple of you had talked about the specific terms that we use when we promote this policy. What do you advise to those who are digesting media about healthcare policy?
Well, just stay alert. There are certain trigger words that are used again and again, sometimes disguised, but sometimes direct, and try to see through them and expose them for the purposes behind them.
Absolutely. And then one other thing I wanted to make sure to ask Anna about, actually, because I've heard you talk about this before. I can't remember if you mentioned it today or not, but it's incredible to me that patients can be moved from public systems to private systems, sometimes without even their knowledge of that occurring. Can you talk about that and how maybe a patient can go about ensuring that they actually understand what their setup is, how they're engaging in our healthcare system?
Well, you're describing direct contracting entities, which have been rebranded by CMS as ACO REACH, but they're exactly the same. In fact, they're probably worse. They are these middlemen that are owned by private equity firms and venture capital firms and commercial health insurance companies they're middlemen in order to lower costs, right? I've never known a middleman to lower a cost anywhere, but this is like hope it springs eternal here. We'll keep doing the same thing over and over again. But how are seniors enrolled is like the most nefarious part. Well, one of the most nefarious parts of this whole system. These are, just as Steffi was saying, these are individuals who have rejected Medicare Advantage and they want to stay in traditional fee-for-service Medicare, right? They do not want an insurance company messing with their care or managing their care. And yet, without their knowledge or consent, they are being enrolled into these direct contracting entities or ACO REACH. And the way that it's happening is that with Medicare Advantage, the insurance company tries to recruit the patient, right? We're bombarded during the open enrollment or open season, as I call it, with Medicare Advantage plans. But with DCEs, they don't try to recruit the patients. They recruit the physicians and the physician practices and the health and the hospital systems. So that's where they go to. They go to the physicians and physician practices. And once the physician joins, then all of their patients come along with them. And so once the physician joins the DCE, then all of their patients automatically become part of that DCE. Without their knowledge, without their consent, they get this letter or this notice once a year to tell them that they are now part of the DCE. And what can they do about it? Really not much. In fact, I asked Liz Fowler, the director of the CMMI, specifically this question: what if a senior doesn't want to be in a DCE? And her answer was, just find another doctor.
Can you explain how that
Right.
presents hurdles for the patient very quickly?
Well, I mean, I don't know, Steffi, do you
I mean, I'm living
you
in
take
New
care
York
of-
City. Try to find a primary care doctor in New York City. Once you get one, you stay. You know, it's ridiculous to say find another doctor, and the other doctor's going to be in a ACO reach as well. So pretty soon, it's going to be, if this goes forward, it's going to be impossible to not be in managed care and not have some sort of corporate entity making profits off of your healthcare for being, as Anna said, a middleman. So, this is just an effort to hand over the Medicare program, which is a lot of taxpayer dollars, just hand it over to corporations for profit making.
Oh, absolutely.
Fantastic.
The
I want to
goal
thank
that
you
the
all.
Sorry.
No, go ahead. Go ahead and finish your thought.
No, it's the stated goal of the CMMI and the CMS is to have every single Medicare beneficiary and most Medicaid beneficiaries in an accountable care relationship by 2030. So that's their goal.
Absolutely. Well, thank you all so much for taking the time to be here. What a wonderful panel. I want to encourage everybody to take a look at the ticker down below if you're interested in helping out any of the organizations. We've had the Patreons running there. Once again, just want to shout out March for Medicare for All, Physicians for a National Health Program, Real Progressives, Yellow Vest Actions, and Indie Left Media for sponsoring these events. And I also do want to plug really quick before we move on to pass things over to Joy for the last panel of the day here. We are engaging in a raffle, so you all can participate. We're raffling off an international gourmet Medicare for All gift basket. It's valued at $150 for every $20 donation to March for Medicare for All. Between the 11th and 14th, you will receive an entry to win. So that's one entry per $20, okay? A $40 donation, for example, would count as 2 entries. And one person will be selected at the end of the week. We have all sorts of treats and swag from March for Medicare for All. We're sending out the deficit book by Stephanie Kelton, who explains some of the funding mechanisms. So if you're interested in receiving that basket, as you can see there up on the screen, please do go participate in our raffle. And with that, I will thank our panelists for taking the time today, and we will bring Joy in here for the next panel.
Hey,
There
Luke.
she is.
Yeah, what an awesome panel. Oh my gosh. And can I just say, Dr. Ted, you are a national treasure. Wow. I love the use of the language and the cartoons to kind of simplify things in an artistic manner. And, just what an incredible panel to set the tone for these 3 days. What's something that stood out to you a lot? Something you learned?
So to me, what really stands out is the extent to which public healthcare programs are just used to siphon funds to private for-profit entities, and how something that might appear on the surface to be in the best interest of everyday working people can be so cynically weaponized to just increase profit for insurance companies and big pharma and other for-profit corporations. I think it's just incredible to get into some of the mechanics of that. And I also was astounded by some of the history of propaganda and things that Ted got into, and how these movements have been so successfully stifled by those who currently get to profit off of it.
Yeah, absolutely. And, I truly appreciate that. And also before I went blind, I worked in healthcare for over 10 years. I worked in SHIP, I worked in pre authorization, I worked in medical assistance, I worked in Medicare. I did all these things. Hearing, some of what I've gone through actually said, and,
Yeah.
you know, shared with people, it's really good because a lot of people, just hear the terms and they don't understand all of the red tape and everything that goes on behind it. So I can't thank you and your panel enough. It was awesome. So why don't you plug the well, I'll be plugging the next 2 days, but plug the other panels you're going to be hosting.
Yeah, so I'll be hosting a couple more panels on Sunday. We're going to kick things off with the at I believe noon Eastern. Do I have that right, Joy? Noon Eastern,
Yeah.
9 Pacific. On Sunday is going to be the international panel and how healthcare is a human right. We're going to talk about the petition to declare it a human right, essentially, and go over some of the international law surrounding that. Then we also have 4 Eastern, 1 Pacific. We're going to talk about the how are you going to pay for it aspect of this. So we'll be bringing some rudimentary modern monetary theory principles to the audience and explaining how Medicare for All is deflationary and therefore you actually want to increase public funding, not to give away too much of the game, but that will be some of the topics that we cover there on Sunday. And I look forward to seeing you all again. It's a sincere honor to be a part of this. And for those that don't know what the next panel is, it's basically going to be Joy leading a conversation that kind of builds upon what we were just talking about in the presentations we just brought to you. With that, I will pass it over to Savage Joy. Thank you so much to everybody for tuning in. It's been an honor to be a part of this.
Thanks so much, Luke. And again, shout out to the first panel. You guys were amazing. So first off, bear with me. I am 85% blind, so if I stumble while I'm reading something, just bear with me. So this is our next panel. So we are going to be essentially discussing some of what we heard, but in a discussion format. Each of the guests, each of the panelists will be giving a 10-minute or less kind of breakdown, a summary of what they'd like to discuss. And then each person, I will then ask a question or two pertaining to what they've said. Then we're going to do Q&A and open it up. So I do want to introduce Karen Palmer, PhD. You are a health policy analyst. And I do want you to introduce yourself further as well.
That's me. I actually don't have a PhD. I have graduate degrees in public health. But that's me. I'm in Vancouver, British Columbia, and I'm happy to be with you.
Thank you so much for joining us. And also, Dr. Andy Coates, you are a physician. So can you introduce yourself further, what your specialties are?
So my board specialties are internal medicine and hospice and palliative medicine. I work at an upstate New York level 1 trauma center, and many of my responsibilities revolve around the frail elderly trauma patients these days. But I've also worked in many other capacities, and with some humility, know the delivery system of my own community, several hundred miles in every direction, quite well.
Right. Well, it's going to be really interesting to hear from your perspectives, being actually on the professional side of this. Karen, would you like to start?
Sure. I thought Claudia was going to go first, but I'm happy to go first.
I'm not sure where she is yet.
Okay.
She may be having tech issues.
All right.
So I'll go with you first.
All right. So I'm speaking to you from Vancouver, British Columbia, where I am a health policy analyst. And I'm going to just take you through what our healthcare system looks like here, and then some of the threats to it, and some of our visions for what it might look like down the road. So it's kind of hard for me to think of Canada's healthcare system as a radical vision of social justice and healthcare, because it's more like a plain Jane variety healthcare system, just like everywhere else in the developed world, except in the United States. So I think maybe the trouble is that leaders in the US think of it as radical when universal healthcare is really just the norm in so many places. So I'll tell you a little bit about our healthcare system, what our not so radical vision is for the future of our healthcare system in Canada, and what some of the threats are. So our system works like this. It's called Medicare, just like yours, except it covers everybody, regardless of their age. We have a publicly funded single payer in each of the 10 provinces and 3 territories in Canada that covers all medically necessary hospital and physician services. So that little phrase, medically necessary hospital and physician services, is a bit of a mantra. There are no copays, there's no deductibles, there's no coinsurance for medically necessary hospital and physician care. And to Canadians, this principle of care based on need, not ability to pay, is a defining national value. So doctors decide what's medically necessary, not insurance companies, as we've heard about in the last few talks. Hospitals and physicians deliver care in publicly owned facilities or in private not-for-profit settings, or sometimes in private for-profit investor-owned settings. But doctors are not typically employees of the government, like in the National Health Service, but rather in the United Kingdom, but rather they are usually self-employed, and they are basically independent corporations. And they're paid by the single payer in their province, usually through fee-for-service, but sometimes through capitation, where they receive a set amount per year for each person that's rostered into their care. And then doctors are enrolled in the single payer plans, which is nearly every doctor in Canada, just about, is enrolled. And they bill just one payer in their province, wherever they happen to be practicing. And enrolled doctors aren't allowed to bill patients too, meaning they can't work in what we call dual practice. So they can't bill both the single payer and the patient. And then in some provinces, like in British Columbia, where I am, the earnings of every physician in the province are reported publicly every year in what's called the Blue Book in BC. So for example, I can see that last year my own family doctor billed $245,242 to the single payer. And the highest biller was an ophthalmologist who billed more than $3 million to the single payer. And then hospitals are mostly funded through one annual global budget for each hospital, with most provinces also using some sort of prospective payment or other funding mechanisms. And Canada's healthcare system is tied together by the Federal Canada Health Act of 1984, which says that in each province, in exchange for abiding by 5 principles, the federal government will give that province or the territory their fair share of the federal transfer payment to help pay for Medicare. And it was the enticement of this financial deal with the federal government in 1957 that finally helped spread Medicare across Canada by 1962, after it first began in Saskatchewan in 1946, when the then Premier Tommy Douglas asked Dr. Henry Sigrist, you'll remember him from TED's talk, who was at Johns Hopkins, to review and advise him on the province's health system. And so those 5 principles are that the single payer must be publicly administered, services have to be comprehensive, so all medically necessary hospital and physician services. They have to be universal, meaning everybody in, nobody out. They have to be accessible, meaning on uniform terms and conditions to everyone, so no user fees, no extra billing, no co-payments are allowed. And it has to be portable, meaning that you're covered if you leave your home province and you go to another province, you're covered through a reciprocal billing arrangement if you happen to be temporarily away from your home province and something happens. So then on top of Medicare, most Canadians have some form of private supplemental insurance for the things that aren't covered by Medicare, like prescription drugs that are dispensed outside of hospital, dental care, physical therapy, massage, acupuncture, optometry, glasses, and a host of other things. And so that's the nuts and bolts of how our system works. So what does our vision of an even more just and equitable system look like? Well, adding universal pharmacare is top of the list. Prescription drugs are publicly funded if you're in hospital, but once you're discharged, they're either covered under employer-based insurance if you happen to have that, which many Canadians do, or through private policies or out of pocket. There's been a very big push in the last few years for publicly funded universal pharmacare. And regulating and lowering patented drug prices is a really hot topic right now in Canada, with public consultations actually underway as we speak about how to do that. The next thing is adding universal preventative dental care. Perhaps that's pretty high on the list. It's not covered under Medicare, except if the care also requires hospitalization, so after a traumatic accident, for example. And there are advocacy coalitions pushing to add that, at least for children to start with. When Medicare came into existence, the alternative to national dental insurance was prevention through things like fluoridation and education on oral hygiene and better eating habits, and a focus on dentistry as an individual responsibility rather than a social good. So that's how we ended up with a patchwork of coverage for dental care. The pandemic has also revealed cracks in our mental health care system and in our home care and long-term care systems for older adults, and fixing that too is part of our journey towards healthcare justice. But perhaps most important to our vision of a better Medicare is that we need to integrate the parts of our system with each other so that care processes become more holistically seamless and rather than being siloed. So our challenge is not really about how we pay for care, but rather about how we deliver it. And that's a big thing that people are working on to improve. So the last thing I'll talk about are some threats. And I would say there are three main threats. I would say that the first is that there's a constitutional challenge to British Columbia's Medicare law. A private for-profit investor-owned surgical facility sued the BC government, claiming that British Columbia's Medicare Protection Act, which parallels our federal Canada Health Act, violates British Columbians' constitutional rights to life, liberty, and security of the person, because they say the law does not allow us to pay privately for faster access to care. So the corporate plaintiffs in this case, called Canby Surgeries Corporation, want to strike down British Columbia's Medicare law so that doctors can charge patients more than the public plan pays them in exchange for faster access to care. And they also want to overturn the ban on private duplicative insurance. So as it is now, you can't buy private insurance that copies what's covered under the public plans. So they want what would essentially be private queue jumping insurance for faster access for those who could afford to pay. And lastly, these doctors want to be able to work in dual practice, meaning they want to be able to bill the public plan and patients and private insurers. I would say the second threat on the list of threats is, like in many places, virtual care exploded in Canada within 2 weeks of the World Health Organization declaring the pandemic. Right now, the total capitalization of the digital health market in Canada is around $20 billion. But along with that has come exploitation of inadvertent loopholes in the Canada Health Act. So for example, one virtual care company has decided that it's okay, according to them, to have publicly funded hours during which patients purportedly consult with a general practitioner enrolled in the same provincial plan as where the patients are beneficiaries. But they also have what they call private pay hours, during which patients pay a fee to consult with physicians who aren't enrolled in the public plan where the patients are beneficiaries, but instead are enrolled in the plan of another province or territory. And so this private pay arrangement is new, and it appears to many that it's interprovincial physician dual practice with extra billing and users charges, which is not consistent with the Canada Health Act and in the eyes of many of us. And the third threat, I would say, is the elephant in our living room, which is that our nearest neighbor isn't Denmark, it's the US. Having a more or less free market healthcare system right next door is bleeding into Canada, causing some to agitate for the freedom and choice, we hear those words now, to wreck our healthcare system by changing it from a single payer system to a multi-payer system. So why do I say that the US is influencing how some Canadians think? Well, maybe you heard about the recent, I call it an insurrection in front of our parliament buildings in Ottawa, our nation's capital. It was also called a freedom convoy. And it was a relatively small group of truckers from across Canada, truckers and others, who drove to Ottawa, and they parked a parade of semi-trucks on Ottawa's streets where they demonstrated incessantly for nearly 3 weeks to remove the vaccine requirements at the Canada-US border, but they also demanded that they replace the government with themselves. And they held the city hostage and wouldn't move or stop honking their horns day and night until a very brave 21-year-old woman, whose name was Zexi Lee, got a lawyer who launched a class action and was granted an injunction to stop the relentless noise. So the protesters blockaded the Ambassador Bridge, disrupting a crucial trade route between our two countries. President Biden got involved. Prime Minister Trudeau eventually had to invoke the Emergency Measures Act for the first time ever. It was awful. There is nothing Canadians hate more than being the center of the world's attention for something so embarrassing. But my point in telling you this is because we heard people yelling to demand their First Amendment rights. Now think about that for just a minute. We don't have a First Amendment to our Constitution. That's your Constitution, not ours. So those protesters were heavily influenced by the same far-right voices that caused your insurrection on January 6th. So all this to say that the sooner the US gets single payer, the happier Canadian neighbors will be, as will every other country trying to fend off the infectious spread of neoliberal policies to one day win healthcare for all. Thanks.
I was saying some really important things too. Bummer. So we're having a panel this weekend on why Medicare for All must be national. However, given the talk you just did, I do want to also ask, what are some of the most common things you hear about Canada's system that you want to debunk when it comes to let's push state by state?
Me?
Yes.
Oh, well, Canada's system unfolded province by province, but I have to say that during this pandemic, I have wished so many times that we had a national health service. We had 13 contact tracing apps being developed, one in every province. There's been lots of times when we've wished that we had a national health service, but we don't. In that sense, it was a provincially implemented system to begin with, but it's a very different story, I think, for the United States because you already have Medicare. You should just drop the age limit to like 0, like birth.
Yeah, absolutely. And after this, we do have I have an exclusive interview with Larry Sanders, Bernard's brother, who was the healthcare spokesperson for the Green Party in UK, and also a UK gentleman who's a streamer, to explain some issues with the NHS as well. So it's kind of like, is that the ultimate ideal? Yeah, I mean, yeah, for a lot of people, but I think it's so important for people to realize, like, we cannot stop. It's always going to be improvement of whatever we're given at this point. Andy, Dr. Coates, would you like to give your presentation now? And I just want to remind everyone to put comments if you want to ask anything, and then the other Andy will be reading them when he puts them up on the stream.
Yeah, I'd be delighted to speak, and I hope Claudia Fagan joins us, who's a treasured colleague and a great leader. This is very hard because talking to the screen is just very hard. I practice in an acute care hospital, a very big acute care hospital, where the privilege of the position is that there's no one in our society who really escapes the hospital. We all face crucial illness, acute illness, hospitalizable illness. We all die. And when I was soon out of training, I realized that most patients who die in a hospital, and that perhaps I should be comfortable with that process if I were to practice medicine in a hospital. And that led to a board certification in hospice and palliative medicine, but it really was motivated by the social reality that people die in hospitals. And I have now attended many, many deaths. With a little bit of social conscience, you can see that there are hideous inequalities, ridiculous injustices, and so many preventable tragedies. With the consciousness of the health policy on the level of Dr. Malino or Dr. Woolhandler, and a little bit of the consciousness of the history as given by Ted Brown, it becomes a very vivid, everyday struggle. So on my service, I will have a patient with managed Medicare, maybe United, maybe Humana, maybe WellPoint, doesn't matter. The managed Medicare will deny the patient acute rehab after their trauma, after their hip fracture, because they are protecting their margin. They want to have a profit, and acute rehab is a lot more expensive than subacute rehab, which takes place in a nursing home. There was a time when I was practicing in Troy, and there were patients who had a particular managed Medicare, and there were no rehab options whatsoever because it was a new product and they hadn't made agreements with any facilities. And so therefore the patients that had just signed up with them for their managed Medicare couldn't get to rehab. There are much more shocking injustices in our system. I would think that medical deportations, in other words, someone without documents, an undocumented person who's severely injured or perhaps needs dialysis in the United States, will be sometimes sent home by their hospital in a extra legal deportation to their home country where medical care may or may not be available. The American Medical Association Ethics Committee took this up and reminded physicians that we have an obligation to a safe discharge plan. In other words, it would not be ethical to discharge a patient to another country where death is certain. So the shocking injustices are there. It's not just a scrum about whether or not patients get a little bit better or a little bit worse benefits. The systemic racism is appalling, and I've borne witness many times in many ways, and I have tried my best to change my local institution, to change my community, to change the consciousness of my colleagues, but the fact is we are pressing against 400 years of history, and we do not yet have the power to reverse things lickety-split. And so therefore, the witness bearing gets to be incredibly painful, and I'd be glad to talk about that. With respect to what we heard tonight, tonight we heard a lot about the health care delivery system, if you can, the medical delivery system, the medicine and surgery that we all need, and how it gets provided and how it gets paid for, and that's a beginning. But I like to say that although I practice internal medicine, the fact is we all know that health and illness springs from external medicine, the real conditions around us, the social conditions we live in, our resources, our exposures. We're all living downstream these days. And with that consciousness, it should lead to an interest and an understanding in public health. And that's why I believe that this call tonight, if you're listening, I have a very hard time imagining who you are because of the screen, but I would want you to know that this is an essential step for this planet. It will take an incredible mass movement of millions of people to get a little bit of healthcare justice in the United States of America. But if that can happen, it will change the world. It is so important. What we understand is that we all will need help. We will all get sick. We will all die. We will all need the hospital. At some point, we all need the help. And the point about healthcare is that it's not altruism for someone to give you that help. It's basic human solidarity. We as doctors and nurses and aides at the bedside and pharmacists and social workers and name your allied caregiver, we do this because we know that we will someday be in that bed, that we too would like to be as healthy as we possibly can, that we will need this help. This is a fact of modern life, and it needs to be recognized as a right. It's a very, very important struggle. And it touches on the question of the legitimacy of the people that rule the society. The people that rule our society are under all kinds of threats about their own legitimacy. Sometimes I think it's comical. For example, the neo-fascists rail against the legitimacy of the government as they scream for the power of the government. There's this incredible contradiction, this incredible hypocrisy. Well, of course, the legitimacy that they want is the legitimacy for no one. The libertarian idea that you can go into the woods and come back with your F-150 sucked out of your thumb. No one made it for you. It just appeared. It's an incredibly stupid ideology. It should be laughed at. It's not laughed at. It's actually the official ideology that we all need to be our own selves, our own country. It's silly. The point about healthcare is that this is the future legitimacy of the leadership of society. Health is essential to freedom. Health is essential to life. Health is essential to education. Everyone deserves their best chance at health, and we mean everyone. This is about justice. This is about equity. Health is fundamental, and we must have health. That's a very big question. That's beyond medical delivery systems. That's beyond going to the doctor. That's beyond the emergency room. That has to do with how society is organized so that people are not made sick by their exposures, so that we have reasonable working conditions and working environments, where we live, our water supply. The big question of external medicine is the question of health. And the government, the people that would lead the future of this society, planet Earth, the people that will lead us forward will gain their legitimacy from emphasizing health and the science that gets us to health. And in that context, with respect to Professor Brown's beautiful presentation, we have seen an incredible onslaught of right-wing activism for 100 years against planning. Never mind socialism, call it planning. We want to have some healthcare planning. We want everyone to have the chance at the best possible healthcare. This is why we invite you, all of you activists, to study the nuts and bolts of this healthcare policy. Because if you understand the policy, you understand how ridiculous it is that we don't have what we should deserve, a dignified health system that's ready for us when we're sick and also wants us to be as healthy as possible at all times. Some of what health policy science teaches us is that user fees, meaning cash when you have to see a doctor or need help, or co-pays or co-insurance, any kind of cash out of your pocket, discourages people from getting necessary care. This is proven many ways in health policy. It is very bad health policy because science tells us that this discourages people from living longer. So we should do away with all user fees. Middlemen, I sometimes joke that there's no problem in the hospital that more middlemen can't fix. Middlemen are not the answer. We do not need more consultants. We need fewer consultants. We need people to get out of the way of the nurse and the physician at the bedside and stop trying to quote unquote gatekeep in the interest of managing the resources. We need caregivers and their patients to make the decisions. And then most corrosive of all, we cannot have profiteering in medicine. The idea that when someone is sick, it is the time for someone else to make a profit is unethical, it's appalling, It is no way to organize a system. And in fact, when it does organize the system, it cheats the patient out of essential resources. I could say much more. I think I'll stop there. I'm very grateful for this opportunity to participate, and I look forward to hearing Dr. Fagan.
Thank you so much. And you bring up an excellent point about environmental racism. And that is one of the biggest issues of why we need national improved Medicare for all, because it does not matter if you are a citizen or what have you. And we're going to start seeing a lot of, climate refugees and what have you. What is in your practice, do you have a particular story that sticks out to you as someone who could not get the care that they needed and had to leave the US?
So fortunately, in my practice, I have had near encounters with medical deportation, and I'm in a position to suggest maybe that's not what we want to do for this patient. But it has certainly been a fact. One of the things that's interesting about New York is that there are patients who do not have documents who are able to get hemodialysis, which is important, right? So that's a big incremental difference. But what should happen if you went home to your home country? Would you be able to continue your hemodialysis? These are very dramatic, real life, modern problems. In terms of the institutional racism, I have had unbelievably painful experiences where, with my patients' families, I have simply listened and understood that they have been treated in the most undignified, unbelievable way. I don't know if any one story wins more than another, but it's a fact of life in this system that if you're poor and not used to sticking up for yourself in a certain way, you might just wait your turn, and that might turn out to be deadly.
Absolutely. I am going to try to bring Dr. Fagan in. Andy, can we try? Can you hear us, Dr. Fagan? Claudia, can you hear us? Make sure to see if your mute button is on. Okay, unfortunately, it seems like she cannot hear us.
I can hear you.
So what I want to do at this point, I'm sorry.
I can hear you.
Oh, yay, awesome. Do you want to we'll just have to not virtually see you, but we definitely want to hear from you. So can you tell us what you wanted to share with us tonight?
It's utterly frustrating because I missed Andy and Karen's remarks. So I'm not sure what's been said. I enjoyed the previous presentation, but I just wanted to remind folks that the United States is the only industrialized country that doesn't guarantee access to healthcare for everyone who lives here. And we spend more per person on healthcare than anyone else in the world. But it's American arrogance that we believe we have the best healthcare in the world and we can't learn from anyone else. That American exceptionalism. We don't excel in any public health measure compared to any other industrialized country, whether it's life expectancy, infant mortality. I think about maternal mortality. which has quadrupled in the time in which I've been in practice in the U.S. And it's not just embarrassing, it's negligent. And you look at, as a nation, we've never accepted responsibility for the health of our country, as evidenced by our response to COVID-19, where people living in the United States, one of the wealthiest countries in the world, had the greatest risk of death from COVID, that we couldn't figure out why we had greater mortality and morbidity among people of color, because those are the people who have least access to healthcare in the United States. That we spend so much money on excluding people from healthcare. The first thing you see when you go into a healthcare facility in the United States, whether it's a clinic, a hospital, or emergency department, it's the registration desk. And the role of the registration desk is determined how will the care be paid for that you're going to receive. And that's the first thing, your first encounter. If you're attending this conference, most people already believe that we already spend enough on healthcare in the United States. We just allow too many people who are not engaged in the delivery of healthcare to take profit from it. And so if we were going to fix it, what should it look like? If we were going to fix healthcare, because I can't really say that we have a healthcare system, but what should it look like? And for so many people, they say, okay, well, fee for service, which used to be quite common in the United States. They say, well, that was the wrong way, because when you pay people for the care that they deliver, that it provides too much of an incentive to deliver too much care. And then we swung the other way and said, well, managed care, that we should, we have capitation, and that we should give health people who are engaged in healthcare delivery a set amount of funds and say, you should deliver the care that's most appropriate. And the incentive there is to deliver too little care, because whatever you don't spend on healthcare, you get to keep in profit. And as a result of that, the United States has never really effectively addressed the question about how do we provide the most care with the funds we have for everyone? When do we accept responsibility for everyone who lives here? And where is it that we have to decide, oh, you're a citizen, and so you're entitled to something more, as opposed to, no, you immigrated here. You know, the late Quentin Young used to say that the problem with the indigenous folks in the United States, the Native Americans, was that they had a poor immigration policy. That we were taken over by folks from other parts of the world who decided they were more entitled to the riches of the country than the people who were here first. And so I take great pride in the fact that I get to be the chief medical officer for a healthcare system in Cook County, which Chicago is part of, where we're able to take care of everyone regardless of their ability to pay. And we don't ask people to prove where they're from or, you know, who they belong to before we decide what care we can deliver. Unfortunately, that is not the model that we have gone with in the United States. It's embarrassing that a country that has so much in terms of resources decides to be so limiting in providing access to care. And we, instead of trying to think about what would improve the health of our population, we have an attitude of, I've got mine, you get yours, and too bad if you're not one of those folks fortunate enough to have access. We, as Andy talked about, the structural racism that exists in the United States today, we act shocked that not providing people the very basics of healthcare. And when I talk about healthcare, I'm not just talking about the medical delivery of medication, but recognizing that healthcare includes safe housing, includes safe food to consume, includes clean air and clean water. It includes having green spaces in which you can exercise and meditate and appreciate the environment around you. We have a very self-absorbed approach to healthcare in the United States. and it means those who have can have, and those who do not have are the have-nots. And oh well, that's unfortunate, but not our problem. So I don't understand the technical reasons why my camera, which was working all fine all evening, is not working. But I wanted to say that we can do better. That every other country in the world, even poor countries, do better than we do, because at least they acknowledge that they have some responsibility for the people who live within their borders. And I'll stop there.
You bring up some really great points. And I would actually, if you could touch on indigenous peoples more, and basically we see the racism within healthcare, and we see the inequities just across the board. We're going to be doing a panel on that tomorrow. What is, lack of sounding, rudimentary, what is one of the, most common things that you see with health concerns of indigenous peoples, as far as lack of healthcare or lack of sufficient healthcare?
Well, we take from the folks who were living here when the Europeans arrived. We took everything from them, including their land, the resources, their culture. We herded them into small encampments and took everything that was meaningful for them. If they were able to feed themselves on the land, they were able to make a life for themselves, and they had basic needs. And we crammed them into small, narrow spaces and expected them to survive without the resources to feed themselves with adequate nutrition, with all that is taken from people, being the daughter of immigrants. But we have people who have lived impoverished and not had access, learn to subside, or on the very, very minimal nutrition, and then are surprised because they have a greater incidence of diabetes, they have a greater incidence of high blood pressure and cardiovascular disease, because we have not allowed them to have the space, the freedom to access the things that they need to have healthy lives. And then we are demean them and humiliate them and look down upon them because they have these problems, because we have created situations where obesity and diabetes and high blood pressure are the results of the circumstances under which they have survived. So, and then say, well, they should do better for themselves.
Yeah, absolutely. And then we're hearing more and more about food deserts. And I think it's so important that people realize exactly what you said, that is absolutely linked to healthcare as well. Is that something you see a lot where you are in the city?
We see food deserts across the United States, but we see them in certain neighborhoods. And in Chicago, we see them all the time. As a matter of fact, as a part of our health system, we've actually partnered with the food depositories, and our physicians can actually write prescriptions for patients for fresh fruits and vegetables. And we have trucks that come to our clinics on a monthly basis to bring fresh fruits and vegetables. And once all of the patients who have prescriptions for fruits and vegetables have received them, then other people, anyone else from the neighborhood who wants to also receive them, can. And so they get a 10-pound package of what's in season in terms of fruits and vegetables, as well as suggestions about preparation. But it's recognizing that we as a country, that healthcare is not just about giving the people prescriptions for a pill, or you have to recognize that we have created systems and that are unsafe and unhealthy, and expect people to thrive in them.
Absolutely. Dr. Coates, did you have something to add?
So we, in my neighborhood, have urban and rural food deserts where the access to fresh fruit and vegetables is questionable on both populations. Poverty, there's been a huge, on the left, there was a big thing about the 1% and the class polarization and how rich the rich had gotten, Whitey on the moon phenomenon. Sorry, but that's a Gil Scott-Heron song. I'm talking about Bezos and the other guy competing to go into space. There's a whole bit of focus on the rich, but in fact, the poor in our country have gotten much more poor. And so if you're worried about the health of your patients, you see the outcome from poverty. And so the question of access to good food supply, which is probably why over the centuries people lived longer, was the food supply increased. I agree with Dr. Fagan that programs that stabilize the food supply are to the credit. But I would say that for activists, for your audience, for tonight, the point is about health outcomes. In the big picture, our country is getting sicker. It's because of the poverty. It's because of these questions like access to good food supply, real jobs that pay reasonable wages. These are health questions. And if we can focus upon the fact that we all need dignified medical services, we can start to enter into that dialogue so that if everyone had access to the necessary care, you think you're having a heart attack, you go to the emergency room, you don't worry about whether or not you're going to be seen. And in fact, you have a well enough planned, I emphasize planned, a planned system so that they expect you, so that they have the personnel to see you in a timely way. They're not doing a just-in-time warehouse. They're not playing a game with profits. They're trying to get ready to see the volume they're going to see, because we looked at last year's statistics and we knew that in our community about this many people are going to come to the ER on Thursday night. And therefore, we're going to process them all within an hour or two. That kind of planning, which we know from science, leads to outcomes. The food question leads to outcomes. The food deserts lead to outcomes. The wait times lead to outcomes. Health activists have science on their side. We all have science on our side to explain that this is unnecessary. We could plan not to have a food desert in the middle of the Adirondacks or in Troy, New York, or in, pick your city, or in the south side of Chicago. We could plan not to do that. We could also plan to be ready for you when you're acutely ill. We have the resources. This is a different vision. And Karen said some amazing things. I mean, she said that it was a defining national value in Canada that people expected there to be a system for them when they got sick. It was a defining national value. I studied history a long time ago, and then when I was a resident, I got a pass to study a little bit of history of the hospital that I was at. It was a 1930s hospital. They had an experiment in collective medical practice along the lines of things that both Doctors Woolhandler and Brown touched upon in their history. And that collective experiment was in fact touted by Henry Sigerist, who I got to know very well as a historian. I've read a great deal of his work. The great titan of 20th century medical history is Henry Sigerist, and everyone who wants to know the history of medicine should read Henry Sigerist. Unbelievable accomplishment academically. So when I read that history, I asked for research into the hospital's history, and in the 1930s, I found in the archives of the board of directors letters from a woman who was a farmer, a dairy farmer, and said, I will never be able to pay your hospital bill in early 1930s, but I will send you whatever I can from my milk check every month. And in the archives, she sent a few cents some months. She sent more than $1 a few months. One month she sent more than $2 over the course of the 1930s. And she paid her debt in full by the end of the decade. And the board of trustees of the hospital respected her honesty. And so they memorialized that by keeping it in their archives. What did I take away from that? My patients think that their illness is a shame. They think it's a personal tragedy. They think it's their responsibility. It is not. You did not wish your own illness upon yourself. It happens to all of us. And that incredible ideology that somehow you are to blame for your own illness and therefore must pay to the point of bankruptcy. Within the last year, I had a young woman, her mother had signed over her life savings to her daughter because her daughter was of very meager means, and her mother had, a robust life savings of maybe $10,000, not a huge, a working class life savings. And she wanted that granddaughter to go to college. And that daughter, as her mother had her terminal stroke, was liquidating the $10,000 to do whatever she could for her mother's care. She was forfeiting her mother's life savings because our system had no safety net, despite Medicare, despite hospice care, despite it was going to be a huge cash outlay. And that's sort of a little bit of a story, but the statistics would tell you that in the United States, end-of-life care is provided by the immediate women family members to great financial ruin. And if you think about it the other way, if we had the pride that we all deserve the medical care, the idea that it's a defining national value, that everyone should have it, then it becomes an incredibly liberating idea. I mean, think about, you're trying to organize a trade union for better wages, and all of a sudden you don't have to worry about healthcare for your people. Think about, you're worried about your children and how they're going to make it in their first jobs, and you don't have to worry about healthcare. I'm rambling. I apologize, but
No.
this is what Claudia does.
So I'd like people to think about it, take it to another level in terms of thinking about it, because if like I said, people who are attending this conference, I think, have already accepted the notion that this is something we should do. And we really need to think about, we don't need to just fund the current system because it doesn't serve the needs of the population. We need to have, healthcare for people that is directed by the people who are receiving the healthcare. That an effective plan will say, okay, this is, Andy in New York or Claudia in Chicago, these are the dollars that we have, because we recognize that we don't have infinite resources, and we could certainly make better decisions given the funds up front and about how we would spend those dollars, and how you would spend those dollars in South Florida, where you have a lot of seniors who retired there and their needs. It will be different from how you'll spend those dollars on the south side of Chicago or on the west side of Chicago in terms of meeting the needs of the population, but allowing the people who are receiving the care to participate in the planning and the decision-making about what the needs are, and whether the needs are about what we really need is to address the opioid epidemic, or what we really need is to address the fact that there's a food desert, or what we need to do is people don't have space. They don't have green space in which they can be outside and exercise safely without gun violence, or accepting the fact that gun violence is a public health emergency, or accepting the fact that people who don't have stable housing, and at Cook County, we have invested in housing because we recognize that people who have unstable housing get admitted again and again. And that if you provide them with stable housing, they can actually take care of themselves. They don't need you to take care of them, but if they have somewhere that they can lay their head at night, reliably, a place, and they can be out of the elements, that their heart failure doesn't have to decompensate every couple of months, that their diabetes doesn't have to be uncontrolled, but it's putting people in control of their futures, in control of their health. And we make these arrogant decisions that the people don't know what's good for them. People know what they need. People know that, the food choices they are making are not the best, but they're making the choices that they can make given what's in front of them. So we have to not only talk about the fact that we're spending enough on healthcare, and we're putting too much of it into the profits of folks who aren't delivering care. But we also have to recognize that we're spending so much on healthcare and not spending it in the ways that would benefit the public the most. This idea that the best thing are bigger and better hospitals is not what the public needs. It's not what will make their health better, and it's not what's going to protect them from serious illness. It's providing the people the opportunity to participate in the decision making and serving their community, and deciding that that small children need place to play, that adults need decent housing, that they need decent food choices. It's recognizing that healthcare is such an integral part. We didn't have any problem, as Ted Brown talked about, how oh my goodness, we were going to socialize all of the goods, whether it was the water or it's fire or police, but we decided that we had to stop at healthcare. That was something that people needed individual choice about. So I think that we really have to think much broader terms about healthcare. And
oops.
You still there, Claudia? Well, I agree. Karen, is there anything you would like to add? I know it's a lot, but I saw you writing a few things down.
No. I'm listening to Andy and Claudia, who I've known for 3 decades, and, reflecting on how many times we've had similar conversations. And, it's easy to feel, I guess, a sense of hopelessness around it all. I mean, I lived in the States for 23 years. I'm very familiar with the circumstances there. But I do think that, that hopelessness, doesn't serve us. I mean, there is so much good energy, at this table this evening, and so much will, and I do think that this is a fight worth fighting. I really do think that.
Absolutely. And, Claudia brings up a really great point that pretty much every single thing that we need is linked to healthcare, be it houselessness or environment or really anything, job creation. It's all linked. Do either of you want to expand on that?
Well, I will just say that, one day I'm going to make a T-shirt that says on one side of it, what is public health? And on the other side, it's going to say, what isn't, with a big question mark. Because just as,
Take my money.
just as, I think I could get rich on that T-shirt. That's just really what Andy and Claudia have been talking about. I also think that, I hear from Claudia, 3 words came to mind. That's what I was writing down. And they were purpose, respect, and autonomy, and those 3 words, sort of sum up what most of us want in life, purpose, respect, and autonomy. And I think that that much of our ability to have those things in our world, has to do with our health. And so it should be sort of at the core. It's the essence of what allows us to, become fully human.
Absolutely. Andy, did you want to add on that?
Yes, thank you. And is Claudia, are you there, Claudia? Can we hear you?
I'm back.
Good.
Because you cut off at an eloquent moment. It was like a mic drop. And then
Can you return to that moment, Claudia?
I think I'm going to need an adult beverage after this.
So if I could, so I think, go ahead, Claudia, sorry.
No, what I was trying to say is that people have to, and Karen got it, they have to have autonomy. They have to be involved in the process. We're too often, especially as physicians, dictating to patients what they need to do. instead of meeting people where they are and allowing them to have some rights of self-determination. People, and Andy, you were right. People don't choose to be ill, but they make the best choices they can with what's in front of them, what's laid out in front of them. And what we fail to do as a society is give them the opportunity to make decisions and give them more choices, right? To allow them to be in charge of what is going to sustain them. And it's offensive that we dictate to folks in this way, and we demean them by telling them they don't know what's best for them, when if they had the opportunity, they would make the choices that would allow them to sustain themselves. And I'll stop at that.
That's a great point. Andy.
Well, I think, Savage Joy, the question is what to do, right? People are going to think about, what do we do? And I think that I actually would want to contribute this. I don't know if it'll help the conversation, but we've been told again and again and again what we're allowed to demand when it comes to health reform. Some of the questions in the earlier panel were about the so-called public option. The public option was this cynical game played by Democratic Party insiders to try to derail people who are demanding fundamental health reform in the run-up to the Obamacare. And their theory was that if you had a public private insurance company that competed on the market against the private insurance companies, it would somehow win the competition because people like the public product better than the private product, when the competition in insurance is to compete for the healthy and the wealthy patients. And the insurance companies are already geniuses at finding exactly the healthy and wealthy patients. Therefore, the public option would be predestined to attract needy and poor patients and not be economically viable as a policy. It was an unbelievably cynical ploy launched at an audience that believes in the magic of the marketplace for ideological, not any kind of understanding reasons. Then the president, who promised to abolish Medicare Advantage, the president who gave a speech at a labor meeting in Chicago in favor of single payer, set in motion a neoliberal policy process in which Liz Fowler came from the WellPoint, vice president of WellPoint for public policy, to be Max Baucus on the Senate committee. I think it was the Judicial Committee who had to master getting the thing through. So you basically literally had a quote unquote reform written by the insurance industry. And in the aftermath of that, because now we're a decade on, that reform, regrettably, and it's terrible. It invited in myriad middlemen, unbelievable conglomeration. My own community, there's a Catholic hospital chain of nearly 100 hospitals. I don't know if it's 70, 80, 90. I don't know the exact number of hospitals. Lots of hospitals, dozens upon dozens of hospitals. And I was at a community hospital where the foundation, the local community foundation, the fundraising people who had bake sales for the poor of the community, so that when someone from the homeless shelter had a special need, you could tap that community hospital foundation, that charitable arm. They voted themselves out of existence in the corporate takeover. So their fundraising, their modest community-based fundraising for the poor of their own community became part of the corporate conglomerate, that chain that owned dozens upon dozens of hospitals, that wears its Catholic ethics on its sleeve. It's just shocking to me, really, that this kind of conglomeration was sweeping through. But the Affordable Care Act made it possible. And then the profitizing, as Karen reminds me, not to call it privatizing. The profitizing of Medicare. The Medicare Advantage program has grown greatly. Every state now hires private insurers to manage their Medicaid program. It's an amazing statistic to think that private insurers who once got most of their income from private employers covering private employees, they now get most of their income from governments, from states in managing Medicaid and in the federal government through Medicare Advantage. That's how they're making their money. It's a first pass metabolism of the money through the private insurer, to use a medical liver analogy. It's just a kind of a crazy policy to guarantee the profits of a private corporation. And so if we talk about a single payer, I'm going to go out of bounds here. Dialysis in the United States of America qualifies you for Medicare. All end-stage renal disease patients get Medicare. If you get dialysis in the United States, chances are you get it either at a company-owned dialysis center owned by Fresenius or a dialysis center owned by DaVita. Two big, publicly traded, for-profit dialysis companies, and their income comes from Medicare. We have a single payer for dialysis patients, and the majority of patients are seen by two monopolies. There are very few not-for-profits.
So the reality is that 95% of dialysis centers in the United States are for profit. And the biggest problem with that, it's a majority of physicians, the majority of nephrologists who work at those systems profit from the system, right? They get profit sharing from the companies for which they work. And that is why the United States has such a low transplant rate, because the physicians responsible for referring those patients for dialysis profit from dialysis and therefore have less incentive to refer people for transplant. In Canada, the plan is to start you on dialysis while they get you well enough and strong enough to get your transplant. And we don't do that. And people ask, why do we allow so many people to die on dialysis every year and refer so few of them for transplant? It's a profit-driven motive. I mean, that's a reality. That's the world in which we live in. And I think that we have to acknowledge that we're spending, trillions of dollars, literally trillions of dollars, and not acting in the best interest of the people who are receiving the care, or even offering them the best care that's available.
Andy, did you want to respond?
Well, Claudia's making the point. I think that we should focus on the outcomes, not on specific policy. And I think that we should have a very, very careful approach to our friends who tell us what we're allowed to demand. For example, a state-based quote unquote single payer, or a little bit of Medicaid expansion, or a little bit of Medicare for some more. I think that I'm in favor of incrementalism. I realize that the system needs to be changed incrementally, not all at once. You can't cause mayhem. You need to have some order. But I would say that the goal is to get the profit taking completely out. It needs to be a completely human service with no one making a profit. It must be a principle that no one makes a profit. It must be a principle that people do not pay out of their pocket when they need the care. These must be built into the system, or you will not end up with a humane system, and we will never get at the inequity, because we have so many disadvantaged people for so many reasons. Institutional racism, number one in our country. But the point is that without getting our arms around having the money out of the system, there's no way we'll get to the next step of having planning for each and all.
Well, I think the problem is that we have allowed the politicians to dictate what the choices were. And they are not necessarily the...
There she goes.
Darn it. But yes, she is correct that we should not be taking orders from them. You know, we have 135 legislators who have signed on to Medicare for All. And what's going on? Nothing. They are absolutely celebrating the fact that, yes, let's lower Medicare to age 60. And those breadcrumbs are supposed to be celebrated. And not just does lowering it 5 years not change everyone's life, it also doesn't help with the many inequities that are in regular Medicare. So yeah, you're all absolutely right as far as the incrementalism. Karen, did you want to add on that as well?
You know, I am reflecting on the time that goes into thinking about this and the amount of space this takes up in people's lives as they try to navigate and manipulate the system in ways that will at least try to work for them. And, you know, it is just not, I mean, I spend my days thinking about how to make healthcare systems better, but how to pay for basic hospital and physician services is not something that I think about ever. When I moved back to Canada, I would stop at the desk at the doctor's office and look at them getting ready to pay because I had been paying in the United States for 2 decades. And they would sort of look up and say, yes. I'd say, oh, right, okay, great, thanks, bye. Because, you know, it took me a long time to drop that habit of stopping to pay. And it's just not something that consumes the lives and undermines the lives of people in most developed countries around the world. And it is just so odd that it still continues to do that. And as I'm hearing on this call, and I'm reminded of, you know, what that felt like, it's something that is far from my mind and from the minds of most Canadians who live here, who don't have to worry about whether they're going to go bankrupt if they go to the hospital.
Absolutely. Andy, do we have any questions from the audience?
We sure do.
All right.
Now, I've been getting them secondhand because of the way that we're streaming. They're not coming into the chat, but you've all met Virginia already in the green room. She's been sending me the questions that she's been seeing in those chats, and so there's a few of them, and I think there's a couple of good questions here, and they're more, I think, from Americans that aren't familiar with certain aspects of the Canadian system. So if
here we go.
yeah, and now they're not. I don't think they're as ludicrous as they usually are, but this one, there's a few here, and there was certainly one that Virginia asked me to ask for sure because she wonders about this. But there's a question from a gentleman named David McClanahan, and
I know David's question. He's going to ask about capitation, right?
Okay, all right. So you know this question already.
That's just too. I think it's too complicated and in the weeds for right now. I know there's capitation in Ontario's healthcare system. I know it less well than the other ones, and I'm happy to answer his question offline. I don't think it's. I think it's a bit in the weeds for this conversation.
All right. Okay.
I can answer that.
Okay.
There's no good way to pay a doctor. There's no good way to pay a doctor. You can pay a doctor by the hour, and doctors can subvert any system.
Well, so that's what I was saying before. You know, they say fee for service encourages excess care, which is dangerous, and capitation discourages encourages underutilization. If the notion is that the dollars that aren't spent in delivering care are kept in profit. You know, the system where I work at a county where I have 1,000 physicians, we are salaried. And they say that with salaried, you're not motivated necessarily to do the best. But, you know, my question is, why are you in medicine, right? You know, there are a lot easier ways to make a living. We actually have certain expectations of our physicians, and it's not in terms of productivity, but did you talk to your smokers about stopping smoking? Did you make sure your women got their mammograms, that they got their pap smears, that your people over 50 got their colonoscopies, or if they had cancer, so you try to give people guidelines to encourage them. But Andy's absolutely right. There's no perfect way in which to compensate people for the work they do, but you try to, because it used to be that people went into medicine or they wanted to be a doctor or a lawyer because those were the most lucrative salaries in the United States. Now you can go into business and you can go into a lot of gig economies. There are a lot easier ways to make a buck. And so we have more people who are into medicine because it's a calling or something that they choose to do. But I think that we could spend a lot of time saying what's wrong with a particular compensation instead of looking at how we make sure we deliver the best care to the most people.
And just to clarify, most doctors in Canada are still paid fee for service, but there's a big movement, especially in primary care, from doctors who don't want to be paid that way anymore and want to be paid salary. They just don't want to have to, in a sense, churn patients in the way that you have to churn patients to make a living when you're paid fee for service. And I think the quote is actually Steffi's quote. Dr. Woolhandler, I think, as I quote her, says, "There are many ways to pay doctors. Some ways are better than others. There are no good ways." And that would be true for how we pay all of us. Payment in general, wages, earnings, salary, income, consult, whatever it is. They all have.
Do,
yes,
right?
Regardless of what you do, there are upsides and downsides to all of that.
Absolutely. Andy, do you have another question from the audience?
Here's another one that is more about how the healthcare system in Canada was rolled out province by province. Mm-hmm. And Virginia wanted to ask the panelists about if the provinces have the purview of healthcare in Canada per province, and there are different wealth levels to different provinces, and they all have slight differences. How do you deal with the inequity of outcomes?
There are equalization payments. There are wealthier provinces and poorer provinces. This is a fight in sometimes with the province of Alberta, which has historically had the oil and gas industry and has been one of the wealthier provinces. And anyways, there are equalization payments to oftentimes the maritime provinces over time because they have been the less wealthy provinces over time. I mean, but generally, the Canada Health Act ties the whole system together in that in exchange for the federal transfer payment, your fair share of that, each province has to provide all medically necessary and hospital physician services. So it's not as if the poor provinces don't have those things. They must cover those things in order to get the federal transfer payments. And they do.
So if you're an American activist, you should not think that translating that to Vermont and Mississippi in 2022 makes any sense at all, because it's a federal system.
Absolutely.
Yeah, I mean, constitutionally, healthcare is the jurisdiction of the provinces in Canada. That is why it unfolded the way it unfolded. And so in the division of powers, hospitals and therefore healthcare, 100 years ago became the jurisdiction of the provinces, not the federal government, who only, only is responsible for planning and distribution of the federal transfer payments to the provinces so that the provinces can deliver the care.
And Andy, I think we have time for one more.
Well, this one is a very simple question, and it's I promised myself I wouldn't answer it, but the question is healthcare possible under capitalism? And I'm not gonna.
This is gonna go till 3 a.m.
It'll go longer if I wade in, but I'm not going to say anything.
So I actually think the question is, I'd like to rephrase it. I think the question is health possible? Because healthcare is absolutely possible if you define it as access to an ICU or something. And there's a lot of wealthy nations where if you need an ICU, you get into an ICU. If you need an emergency room, it's there for you. Healthcare, the delivery of, of a provider can be accessible to you. That's if you define it that narrowly, then absolutely. But I think that the question is, do the people in charge of this system, which is obviously a capitalist system, own up to their responsibility for the health of everyone? Because that's the question of the modern society, is whether or not we can basically be safe and sound in order to be, therefore, some kind of idea of free. I mean, I think it's a precondition. I think that it's a big question. And of course, if you look at the corrosive effects of many of the jobs and such, you could say that, well, healthcare is inimical with capitalism, but you might also say maybe health itself. Who wants to work 5 days a week in a time when we could work 3 days a week? These kinds of ideas. I think we're in a really tough time for trying to understand navigate the ideology, if you will. I think the old-fashioned indictment of capitalism holds up pretty well, but it's not the time anymore of other socialist examples that make sense to people. Right now, we have an inter-imperial rivalry fighting for the turf of Ukraine. It's kind of this unbelievable World War I craziness. We also have neo-fascists and a kind of a post-truth moment. So I think that these kinds of questions about the ideology, whether we're anti-capitalist, I think it gets to be very, very murky. And what I would point to for the reform for the health of each and all, and the idea of health equity, the idea of eradicating justice, which is a very big dream when it comes to health services, I think these things have social science measures which we can use as guides. Maternal mortality in the United States, for example, is a damning statistic, and we need the people that are running the society to put the resources in a way that will reduce maternal mortality. And we have a big dream that we could have the best possible care for all, because we have so many resources in the system, as we've heard tonight over and over again. There's no excuse for us not doing a beautiful and dignified job for every one of our patients at every presentation. And it's keeping that alive. I think that builds a movement. And I would just say one more time, it's going to take a movement of millions upon millions of people if we're going to win this progress. It's an organizing job, person to person to person. It's a big job, and it's doable.
Claudia, would you like to expand on that as well?
Yeah, I think the most important thing that finishing with Andy is doable. We tend to think that, so this is a social justice movement, and people fail when we don't think about that, and earlier I was talking about, we allow the politicians to be in charge. Politicians have never led in any social justice movement in this country, or for that matter, in most other parts of the world. What they are focused on is getting reelected. And if you get a parade going, they're going to run to the front to be out in front, but they are not going to be the ones who started. And so I think that as soon as we can get the public to think about that, this is a movement that will come, the public will dictate this to the politicians. We will mobilize, as we have for other movements, that when people are mobilized and activated, when people are in the streets, when people are daily demanding, that is when we will see change, and it will come rapidly at that point. But it is not until that's when politicians become afraid, when they see a loss of control, when they see masses of people demanding and they don't have a quick and easy answer. And yet that is when we are most effective in affecting social change in this country, whether it was ending a war, or whether it is providing voting rights, or whether it is providing um, access to education. We are most effective when we are angry, when we are in the streets, when we are standing shoulder to shoulder, demanding that to which we are entitled. And I think that if people begin to think about um, improved Medicare for all as a social justice movement, we can do that. We have done it time and time again. And it is old fashioned um, activism that when we are most successful and effective. I'll stop there.
Karen,
The only other thing we can do would be to shout everybody in and nobody out, right?
Yes, absolutely. Karen, did you want to share any last thoughts as well?
Just that it's, the rest of the world needs the United States to do this, because the rest of the world, the movement for universal health coverage or universal health care, is in many countries. And so, countries are looking to try and win this in places where it doesn't exist, and in countries that have it, hoping to hold on to it. And the United States has historically been, a powerful and influential country, and and remains so. And so, I think that the rest of the world looks to the United States to get cracking, and make this happen.
Absolutely. So before we go, I definitely want to go around, and if you have a Twitter, email, website, anything you want to give people, anything, any way you want people to contact you, or anything you'd like to promote. So we'll go around in this circle. Dr. Claudia.
I'm trying. Oh, yes. So I'm at one for single payer on Twitter. I'm really bad. I had to go look up my Twitter handle. But one for single payer is at ONE, then the number 4, and then single payer. Because I'm going to keep saying that until we get there. And I know we know that that's if you ask people about single payer, they won't know what that is. But if we say improve Medicare for all, they will. But I'm going to keep fighting for that one for single payer. Thank you.
Thank you so much for joining us. Karen.
I'm at Karen Palmer, PALMER, YVR. YVR is the airplane code for Vancouver. So at Karen Palmer, YVR on Twitter, and happy to hear from you.
Awesome. Thank you as well. And Dr. Coates.
No, I'm not on Twitter.
We're going to work on that this weekend.
In 2021, no. Trisha Greenhall notwithstanding, 2021 I worked all but 9 days, and literally I worked 7 days a week. I'm going to try to be a better activist in 2022.
Awesome.
Any messages that are forwarded, I'll be glad to entertain. But I thank you so much for this.
Thank
and
all three of
solidarity
you.
to all.
This has been amazing. This first night really set a good precedent for the next 2 days. This has been amazing. Shout out to Anna, who scheduled everyone tonight. It's amazing that all of you have known each other for decades as well, so you can play well off of each other. We cannot thank you enough. This has been incredible. We've learned a lot, which is the most important thing. So again, just thank you so much. We appreciate you sharing everything with us tonight.
You're welcome. Thanks for letting me spend the Friday night with my friends.
Yeah. Good to see you, Karen. Even though you couldn't see me.
I see you, Claudia.
Thank you so much. And everybody stick around. We still have more. But thank you so much, everyone. We appreciate this.
Take care.
Thank you.
So coming up, Night is not over, but seriously, like, how good were those two panels? Oh my gosh. I took so many notes. I learned so much. This was amazing. So thank you to everyone who has tuned in. So now we have a few treats. So first we're going to see an exclusive interview I did with the only so-called Bernie bro, Larry Sanders. And we did that specifically to premiere tonight. For years, he was the healthcare spokesperson in the UK Green Party. He still lives in the UK. So we talked about NHS and privatization and everything like that. So it's very educational because we do talk to a lot of people who say, yes, national improved Medicare for all, but NHS is better. So I want people to understand that that fight is not going to end, even if. So we have that. Then afterwards, we have a video from UK commentator Cavernacle. Colin sent a video about his experience dealing with healthcare in the UK. And then the third piece is we're going to have a video I found of people in the UK being asked what they thought prices were for healthcare services in the United States. You're not going to want to miss these three things. But then, of course, we also have Jessie Jet afterwards as well. So stick around. I look forward to seeing your comments, hearing about your comments from the next hour or so as well. So stick around. We definitely have more. And don't forget to tune in the next 2 days as well. This is a 3-day forum. But yes, take it away, Andy. Thank you. All right. So I am here with a very special guest, Mr. Larry Sanders. And yes, he is Bernard's brother, but he is actually quite experienced when it comes to the NHS. He is in UK, and we talk a lot about how Medicare for all, national Medicare for all, would be what we fight for, but a lot of people do feel like the NHS would be even better. So I thought, who better to talk to about the NHS than Mr. Larry Sanders, who you actually were the spokesperson for the UK Green Party in regards to healthcare. So thank you so much for joining me again. I always love speaking to you. So first of all, just kind of on a more basic question, what do the people in the UK as a whole think of us Americans and our healthcare system?
Well, insofar as they think about it, most of what they hear is very worrying. And I want to tell you that the NHS and British health is not a utopia. But part of the problem, the structure is fine, the principles are fine, but to have a good health service, you have to have the staff, you have to have the money. And when you have a right-wing government, as you frequently do in the UK, the health service suffers. It doesn't suffer as much as it would if it were privatized, and bits of it are being privatized. So when you ask me what people in this country, a large part of what people who are following it here is that there are, in fact, some of these terrible American companies that have done so much damage in the US are actually buying their way into the British system. So that's one thing that you hear about. But it'd be important to know that actually Americans pay per head about twice as much for healthcare as we do in the UK. All the key statistics about how long people live, how many children die before they're born, or in the early, the early weeks and months of their lives, lives lost by women in childbirth and in pregnancy, all sorts of statistics that all governments keep. In fact, the US is pretty far down the list. And the UK is not great. There are countries ahead of the UK, but we're way ahead of the American results, and we do it at half the price. If we had the American money, the UK, the NHS would be a utopia.
Yeah, absolutely. And since since its inception of the NHS, has it always been something that, big money and the elite and the establishment has tried to take on?
I suppose the answer is yes and no. In the early stages after the Second World War, when the discussion became serious about a national health service, when the Labour government was elected, a left-wing Labour government was elected in 1945. It's interesting. I think for us, you and I, it'll be very interesting to note that the polls that were taken in the United States and in Britain about having a national health service, a universal health service, were pretty similar. In both countries, a majority of people wanted it, something in the 60%, 65, 60%. There was not a lot of, I haven't studied it that closely, but basically the moral is that the people in favor of a universal health service, free health service, the numbers were very similar in the US and the UK. In the US, we had the horrible business of 1946 election in which the Republicans took control of Congress, and Truman, who was obviously not the most left-wing person in the world, was quite strongly in favor of a universal service, as had FDR, of course, been. So that turning point when the Labour government won a big victory and succeeded in starting an NHS against, and this is important, against the Conservative Party that voted against it dozens of times, against the medical profession at that stage, although now the medical profession is almost entirely in favor of it. Very few people who don't, doctors and nurses and whatnot, that don't like it. But at that point, it was different. So in the US, we had this misfortune of this really particularly nasty Republican Congress elected, which destroyed our chances. And if somebody has the stamina and to do it, they could figure out how much money and how many lives that particular vote in one particular nasty Congress has cost the people of America. So I don't know. I think I got a little lost there, but
no, it makes perfect sense. And what are your thoughts as far as right now? It seems like people like Pramila Jayapal, who wrote, the bill after Bernard, they're, now they're saying, well, it's great if we lower Medicare's age from 65 to 60. What are your thoughts as someone, with the NHS on that incrementalist approach?
Well, I mean, that's in the hands of political judgments at given times. There are times when it's sensible to make those kind of compromises. It makes in the principle of the way the service works, it makes no sense. All these compromises that I've seen that have been put that are short of having a proper universal free service rely on using the current service. And somebody has said it's like putting extra money into a leaky bucket, or like water into a leaking bucket. It flows out, and it doesn't flow out into to good points. It goes into the people who are making the profits to start with. So most of those things, they may well be better for some people, and something that is better for some people is good. Saving people's lives in their measure, is not a bad thing. But the structure, anybody who says that a universal service is not the most efficient way is wrong. It is the most efficient way. It may be at a particular political moment, the right thing to do, but in terms of a general policy, the cheapest, most effective, most life-saving, the most decent thing is a universal service in which everybody gets the care that they need. That's the crucial bit. is not based on your money. It's not based on how clever you are buying insurance or how lucky you are with an employer. It's based on the fact that you're a human being who has certain medical needs, and those needs ought to be met as well as that society can meet them at that time. And that is the bottom line. It also turns out to be much more efficient, because instead of having hundreds of billions going to insurance companies, it costs you about 20 cents a person to sign them up. It's a very easy to include somebody into a universal service. Almost all that stuff is unnecessary, wasteful, and in the end destructive. Yeah.
Right. Now, right now, President Biden has the ability to sign an executive order for 1881A to give all of us Medicare for all during a pandemic. But he has not listened to our requests, and he has stated literally he would veto Medicare for all. He also, when campaigning, said he would give a public option, which is, of course, breadcrumbs, but he has not even done that. Right now, we have over 50 million people uninsured and over 40 million underinsured. So what is it that you think that we as Americans can do?
Well, it's not really a question I can answer from this distance. I think that Bernard, it's been central to his politics since he started, from the day one, and really before that. It's always been part of it. He's always understood the need, and he's always fought for it. So I, like in many other things, I would take my lead from Bernard. Bernard is 100% in favor of Medicare for all. We have talked about whether the difference between Medicare for all and a national health service is that the vast majority of the actual treatment is provided by employees of the state, by it's complicated, and I won't go into the complexity, but they're basically employees of the state, and in Medicare for all, they're paid for by the state, but they're employed frequently. Some of them are employees of the state, like the Veterans Administration and so on, but most of them are employed by private companies, and that is a problem because it leaks money. But it's much less of a problem in the situation you've got. So I think Biden is wrong. He's on the wrong track. Where it comes from and why that history is there, I haven't examined closely enough. But it is a mistake.
Yeah. Do you think that Bernard will be reintroducing his Medicare for all bill?
I don't know the detail of it. He certainly has never given up for a second that being sent to his political work. But whether or not he'll do it, I don't know.
So what is next for the NHS? Being there are corporations, and from what I understand, the US is actually, part of the problem. What is next for it? Are people genuinely scared in the UK that they are going to lose their health care?
Well, we won't lose it entirely, but it's being nibbled. So I'll start with a positive side to it. I'm very pleased that recently, a couple of months ago, I proposed a motion to the Green Party of England and Wales, of which I'm a member, that we have a social care system that is all the services that people with disabilities and the people who help them need. At the moment, that is not like the NHS. That is not free of charge. It is means tested. If you're very poor, you will get the services free. If you're not very poor, you will not. It's a very ineffective system, and it's gotten much worse, and it's proved a disaster within the pandemic. So we passed a motion that called for a number of things, but the central one is that social care, I think in the US, people call it long-term care more often. So it's also nursing homes, but it's also care in your own home. If you've got Alzheimer's, if you're learning disabled, if you've got a mental health problem, if you've got multiple sclerosis, almost anything that makes it harder for you to do things, then you need help, and just like the health service, it is better if it's a free service. Free means that instead of people paying when they're ill and they can't do things and life is very difficult, the services are paid for by people who have the means to pay. It's not free in any other sense, but it is better for people with lots of money to be adequately and fairly taxed so that the services can be provided, so that the people working in the service can use their energies and their brains to do the things they think are necessary for people with people, rather than worrying whether they're going to get paid. So that we've passed that, and to make sure the other side of it is having the money to make the services available is vital. But you also have the services have to be delivered in a certain way. People have to have rights. You can't just be treated high. There are doctors who are paid nicely who don't do their job well, who are offhanded and high hat and all the rest of that. And we know that. I think the vast majority are actually very good at, and it's a lovely way to earn a living, to be able to help people without having to worry about your own finances. But people are entitled to be in charge of their own care, and that's another part of it. There's a very good United Nations Charter on Disabled People, rights of disabled people, and we've said that in our motion, which is now the policy of the party, is that we will pay, the services will be paid for like in the NHS, free at the point of use, and people within that will have specific rights guaranteed to them by the state to put them in charge of their own care. So I'm very pleased with that. We're trying to make it an issue in local elections at the moment. Unfortunately, the Labour Party, which under Corbyn had similar policies, not quite as good, but similar, has moved to the right, and they're not interested at the moment. I think that's a good opportunity for us to win some votes, and I hope it presses the very many very good people in the Labour Party to be stronger in working against their own leadership. So that's something good. And I think it's a principle. Instead of always being on the defensive, worried about what's going to come down the line that's going to make things worse, I think we need to go on the offensive and say, actually, we want a better system. We want more. We want a better life for everybody. All the things that people like you and like Bernard fight for all the time. But the other side of it is, which you are hinting at, and not more than hinting, things are getting worse. There's a bill that's going through Parliament at the moment, and since the government has a big majority, they will in the end pass it. Although I think there've been a couple of amendments that made it less horrible. But basically, it divides up the NHS quite cleverly, because it's very hard to sell off a system that's providing care for 60 million people. It's a vast, multi-hundreds of billions, I can't remember how much money, a lot of money. So you can't, but if you chop it up into pieces, and they're proposing, I think, 42 or 44 local bits, then it becomes easier. And they have systems built into it where some of the providers will be private. If you're providing a service, whether you're an NHS provider or a private provider, you'll have a seat on the board. You'll have a decision-making proposal.
Absolutely. I just have one more question. As far as environmentally, in 2019, the UK did declare a climate emergency, as some of the countries did. Granted, some people think it's just, posturing, it's just words. But we haven't even done as much as that in the US. Are you noticing effects of people health-wise in the UK as far as water, pollution, anything like that?
Yeah. Well, the current government, anything they do or say is on the feeble side. They may not be as bad as the American government, but they're not good. As far as pollution goes, it has been a serious problem here, and more serious in some places than others. Traffic pollution, yes, and all the usual symptoms um, the flooding we've had droughts. So all the things that are happening to the world because of the climate disaster are happening here. I don't think the British have as much in the way of a denial thing, but politically it remains a problem. Anything that's going to take money from people who don't want to use their money, corporations and so on, they fight every inch of the way, even when they say, mildly encouraging things. So yes, I mean, I don't know where we stand internationally. We're probably in the middle, not terribly good, not the worst, but basically nobody has grasped the nettle. Yes, if we don't switch, and it's quite ironic that part of the horror with the Ukraine at the moment is that we're sending huge amounts of money to the Russians for their gas and oil. If we had built the renewables, the turbines and the solar panels and the rest of it, we wouldn't need that. It's so pathetic that we're spending money not just with the Russians, but with the Saudis and with fracking and all the rest of that. When the sane thing, the cheap thing, the safe thing is to have renewable energy, which we could have done, and we can still do it. But every year we waste. I've been in the Green Party for over 20 years, and for the first, I didn't know a lot about environmental stuff at that point, and I learned in the first few months, and all the evidence was clear then. If we started then to shift energy and to insulate houses and all the simple things that need to be done, most of the disaster we're facing wouldn't be needed, and it would have been quite cheap. So it's very sad to see, and most of it was done in order to make some people some extra profit.
Absolutely.
So there are consequences to having bad people running your government.
Definitely. And we're seeing money is pretty much the cause of everything that is suffering in every category. And, Bernard woke us up to that. I'm telling you, he gave us a free education as far as that went. Yeah. Is there anything you would like to add before we end the interview? Oh,
not really. You've asked me some very good questions. You saw the NHS in operation in the middle of it, which not everybody gets to see. And it's been a pleasure to talk to you and to hear from you over the years. Thank you very much.
Thank you so much, Uncle Larry. And we send our love to you, your brother, and all the fellow UK citizens who fight for us and speak their mind that we need better healthcare. So much love, and always great to hear from you.
Thank you so much.
Take care. Bye-bye.
So hey everyone, Joy has asked me to speak about the UK's own healthcare system while you guys are talking about Medicare for all. Of course, the UK has had a socialised healthcare system since I think 1948, so a very, very long time. Of course, that was established by a socialist Labour government in the aftermath of the Second World War, when the UK was essentially on its knees, so that's something to keep in mind when you think about people in America who say that America couldn't afford it. Now, I want to talk about my own experience with the British healthcare system, and maybe at the end contrast it a tiny bit to the American one, and even how you're getting ripped off for your private healthcare, because I've gone private for certain things, and then I've seen medical bills in the US for the same things that are like over 10 times the price or something like that. So yeah, so for me personally, I haven't had much, poor health in my life, but one accident I did have was when I was playing football. So I was playing football training for my team, and there was like a metal bar connecting the goal to a metal fence, but it kind of like all blurred into one. And I remember I was running backwards to tackle someone, and I tackled them, and the momentum of me running took me behind the goal, and I hit and I must have like reacted weirdly. I broke my nose and I cut my head open. You can see the scar still there. You might not be able to see the broken nose so much. You can see a little scar there as well. So basically, that's a head wound. My gash on my head was massively like open. I had to go to hospital. Obviously, I couldn't say like, I'll walk it off or something. And people often don't go to hospital for broken noses, but again, it's something I would want to do anyway. But then, luckily for me, we live in a country of universal healthcare. So the manager called the ambulance. I waited there. The ambulance came and picked me up, strapped me to the bed, took me into the back of the ambulance, offered me laughing gas. I said no because I didn't want to be put under anything at that time. And then they took me to the hospital, wheeled me into the hospital, waited for about, I guess, 20 minutes or so, then taken into a room. My dad came because he was just worried and my parents worried. Then a nurse sewed up my head wound, most painful experience of my entire life, and getting loads of anesthetic in my forehead, which is apparently one of the worst places to get it. And then I cleaned up the blood and I scheduled a consultant appointment at the same hospital. So I went in, I think, a couple of days later, and I had a consultant appointment. They said, we can book you in for 2 weeks' time to fix your broken nose. And then if there's anything further you want to do afterwards, you'd have to pay for the cosmetic angle, but your nose is like broken enough, we're going to pay for it on the NHS. So I think 3 weeks after I broke my nose, I go in for the operation. I think it takes like 6 hours. I get there for about 12, leave about 6 p.m. and obviously that's the anesthetic and the waiting room and getting like some food afterwards as well, all paid for by the hospital. And then I have a follow-up appointment just to check how it is, and of course I get the stitches removed as well, and that cost me £0. Of course that I pay my taxes, I pay my national insurance, which is a special like tax as well to pay for things like healthcare, but no upfront costs, no like £1,000 fee for the ambulance to the hospital, nothing for the operation, nothing for the anesthetic, nothing for the stitches or anything like that. Completely free, no out-of-pocket cost there, paid for by my taxes. And that's why, you want something like universal healthcare, which can provide for you in an emergency. Like, what am I meant to do? I've cut my head open. I can't not go. But potentially, if I was in the American system, that could, eat all my savings away. Now, I also have had like neurological problems, and because of conservative cuts to the NHS and the pandemic, it was very hard to get an appointment. So I scheduled a private appointment and got an MRI scan for £300. To me, that's a lot of money. I've seen bills in America where MRI scans are $4,000, just to show you that not only are Americans being ripped off by having to have this privatized healthcare system, the privatization of it has allowed insurance companies to rip you off massively just for their profits. So that's another facet to all of this. And then, of course, a lot of people get sick when they're older. My granddad has had like various cancers and Parkinson's, but of course he's paid his taxes his whole life. And that cancer treatment is very expensive. But in a universal care system, you expect that when you get to that age, and you hope you'll be taken care of. And that's obviously the way forward. You don't want to make everything to do with your health a for-profit enterprise. So I just wanted to give you guys my experience of this stuff and hope it's enlightening. And I wanted to give the context of it all just to show you like, this is something Americans can afford, something Americans can do. And it's pretty sick and gross to privatize healthcare, and that's why in the UK we have to fight so hard against the conservative privatisation of the NHS that's going on right now.
And here we are.
Hey, Andy, were you going to play the video of the
I know, but I decided to catch you by surprise because you left me here alone. I was very lonely.
We have fun here.
Yeah, it's nice being in charge.
Power.
Okay.
Wait, what's going on?
We'll get to that. We'll get to that video now, Joy.
Okay.
$10 grand for a baby.
Is there a price for that?
Yes.
Jeez, $100, $200.
$2.5 grand. $80. $600.
$250.
More.
Shut the fridge.
More.
£300.
Double it.
$600. $600.
Yeah. Ambulance call out. How much do you think that costs?
Zero payment.
Zero payment.
Yeah, zero payment.
No. It costs $2,500.
For real?
Yeah.
Oh, okay, cool.
you look. An inhaler.
$100.
Yeah, you're pretty close. It's a bit more.
120.
250 to 350.
For an inhaler?
Yes.
Man. So if you're poor, you're dead.
I know that it's like public healthcare in the UK. In the US, fortunately, I'm able to get healthcare through my parents, their jobs, but like I carry an EpiPen, and I know that like the cost of that has just been rising. So like there's like very few companies that even compete, so it's sort of like a monopoly for the EpiPen. Even though like we have insurance, it cost my parents about a couple hundred, even with insurance.
So 2 EpiPens. How much do you reckon they are?
$80.
600.
$40.
I'm afraid not.
More?
More?
$100.
More.
150.
More.
250.
More.
Shut the fridge.
More.
£300.
Double it.
$600. What? Why?
That's a very good question.
$600.
Yeah.
For me, it's more like just hives and shortness of breath. So it wouldn't be like an immediate death situation, but like, so I've been fortunate I've not had to use it, but it's something like keep on me. Like I have my backpack right now, I have it on me.
Cost of childbirth.
Jesus. 50 grand, something ridiculous now.
Yeah, see, I've blown the figures up on your head now, haven't I? Because they're larger. It's the highest, generally speaking, is about 30 grand.
Okay.
Is that reasonable? You haven't?
Not reasonable at all. It's just like now we're on like we're on a benchmark.
100? 200?
Dollars.
Yeah.
The average is about 10 grand. It can go up to 30,000.
10 grand? For a baby?
Yeah, well, I guess. How much is your child worth?
Yeah. What, is that like the same everywhere?
Yeah, the average is about $10,000. Yeah.
That's mad. Oh, no thanks.
Okay, no thanks. In which case, the coil, IUD, contraception, how much do you think that costs?
For one person to implant $1,000?
Yeah, a little bit higher.
Really?
Yeah, $1,300.
Oh. Mental.
I wonder if you could tell me how expensive you think calling an ambulance out to your location is in America.
I guess it depends on like where you live. It really does. Is there a price for that?
Yes.
Jeez. $100? $200?
$2.5 grand.
For what? Why? Why?
Give birth by C-section, and you would like to hold your baby after you've given birth to it.
Actually, yeah, that's what you do. Yeah. You have to pay to do that?
Yes.
To hold my own child that I've been carrying inside of my womb.
Say something else.
Sorry, I was.
But yes.
Jeez.
It's not actually that expensive.
Mate, charging me, I'm gonna punch you.
Yeah.
Not you, but the doctor. Like $100.
$40.
$40.
For skin-on-skin contact. What do you think of the NHS?
Literally the gift that keeps on giving. Literally, people are so dumb for taking advantage of it, and I don't want it to change.
Fine, does it make you grateful for the NHS?
Absolutely. I mean, I didn't know how much free healthcare we got like just off the bat, but like knowing you have to pay like 30 grand for a child, it's outrageous. It really is ridiculous. So thank you, NHS, for your hard work.
I'm genuinely speechless.
Presumably you had an idea that healthcare was expensive in the US.
I didn't realise how expensive. Yeah, I'm just like, what? If you don't have money, you're fudged. Yeah.
What do you think of the people who are profiting off the sale of these medicines?
You're bastards. Sorry, beep. I think, I think they should be stopped.
Ain't that the shit?
That's putting it mildly.
Oh my god. I can't, like, that video just sums it up so perfectly.
Yeah.
So because I showed the interview with Uncle Larry and the cameo with Cavernacle, I thought it was, being they're both in the UK, it was fitting to show that. Yeah. And yeah, they're right. Shut the fridge. We're mad. were bastards.
Yep.
That is insane. Like, skin on skin contact to hold your freaking baby. Are you serious?
I know,
Like,
it's mind-blowing.
oh my God, this is such madness. So we have actually talked a number of times about Medicare for All, the issues with, state by state, incrementalists, breadcrumbs, things like that. So let me open it up kind of broad. What do you want people to take away from this summit? People who are maybe on the line of, I don't know if we should fight that hard, or maybe if people think that, well, my insurance isn't that bad. What is the overall, sentiment that you hope people get from this 3-day forum?
I feel like an awful lot of people in our own country would probably be surprised at some of the figures in that video, that we don't even understand the depth of how outrageous some of the costs are for things that shouldn't have a cost attached to them. I think the first step in us getting somewhere with healthcare is just everyone understanding that there's no reason we can't have universal healthcare. There's no reason we can't have better, and we deserve better by far. And that's a very easy common ground to achieve with people. And as soon as you understand that and realize other places have it and it works just fine, and if for the faults that there might be, it's infinitely better than people going into debt and losing their homes because they needed, medicine or they needed a procedure. And it shouldn't be difficult to get people to agree on that. Yeah, I think the first step is just getting everyone angry and to understand the figures behind what our system actually does to people and what it costs people.
Yeah, I mean, we're watching eugenics of the poor. We're watching violence. We are watching murder by proxy right now. We are seeing people unnecessarily die continuously. And we're watching that Biden himself has a way to do 1881A executive order and literally give every single person in our country immediate health care. Yet, well, in fairness, he did make an executive order for cryptocurrency 2 days ago.
So, progress comes in many forms.
Hey, guys.
Oh, here goes Andy.
Hi.
What you want, boo?
Do you mind if I weigh in for just a quick anecdotal story? Okay. So I've been, my activism in its current form started at the beginning of 2019. And one of the biggest things that I had to learn how to curtail was being cavalier about talking about healthcare issues or stories, right? Because it would be nothing for me as a Canadian, I can assume that people know where I'm from, to just talk about, well, I've got a doctor's appointment today, or a family member has a procedure or something like that, and being cavalier about that to a group of activists that are mostly based in the US that don't have that option. Right. And not think and having to remember that when I say things like that, that's a big deal, and that can really put people off. To someone that doesn't get the coverage through their work, or that has to pay out of pocket, or can't go to the dentist because they can't afford to, or can't upgrade their eyeglasses because they can't afford to. Right. That was a really big thing for me in my own mind, because I didn't want to be that cavalier that, oh yeah, well, I'm Canadian, I could just, I'm it's all good. Right. And that was a big deal for me when I started.
That's a really good perspective. I didn't even think of it that way.
And it's funny because when I explain to to American people, like I literally don't have to even take my wallet with me when I go to the doctor's office or go to the hospital. I have to have $6 for parking.
I've taken Ubers to the emergency room.
Yeah.
It's insane.
Bananas.
Yeah, and I can't believe, like, I think that a lot of Americans, well, the American propaganda machine clearly has always been the greatest propaganda generator of all time, right? And the entire issue with the Cuban Missile Crisis that led to the U.S.'s embarrassment in that situation, which for the foreseeable future will always, levy sanctions against that country that tries to maintain a stranglehold over them, right? Well, and I as a Canadian, I go there and I have a ton of friends in Cuba. And when I go there, I will pack an extra suitcase and bring clothing and toiletries and whatever to them, because that's something that a lot of them don't have access to because of the embargo that's in place against Cuba by the United States. They have free health care.
Yep. Absolutely. Thank you for that perspective, Andy. I've never thought of it that way. Jesse, you we've been friends for quite a while, but as of late, you've really been making music more politically inspired. So I'm kind of wondering where that came from. Like, what was your catalyst to, because initially I would always be like, cover this song for me and do this song for me. And now you're like, you're doing your own thing, and it's, it's profound, it's poetic. So what was the catalyst to switch over like that?
I mean, I'd had a couple political songs for the most part ever since I've been playing out and playing music. I did originals and I did covers, but my originals, they might have a couple, political things here and there, but they weren't strictly political. It wasn't till the beginning of 2020, once quarantine hit and I had all this time on my hands, that I was, laid off, and I was like, what better time than to just start making music about everything that was going on, watching the primaries unfold and become the shit show that they were. And that was when I got on Twitter, because I had mainly one political piece that I wanted heard, and I wasn't going to bother friends and family with it. And so I went to Twitter and tried to find, Bernie supporters and like-minded people and share it with them. And the feedback I got from them and the friends I made there really allowed it to snowball into, next thing you know, I was writing something every day, something every other day, just trying to kind of keep up with the discourse and keep up with whatever, new horrible thing we had to see happen. And I ended up with my first album, The Virus, which is 24 tracks. I wrote that in about 8 weeks or so, of just this kind of way too fast of a pace to keep up with now. But it was just, I would get my son to bed, I'd make a pot of coffee, and I'd stay up recording until 4 or 5 in the morning. And after that, it just became kind of one thing after another. Since then, I've put out 3 more albums of political music and 1 of spoken word that was all political as well. And about halfway through recording my next album, which is called The Grift, and will be out as soon as possible.
It's dedicated to me. I admit it, finally. But I love that you use music to tell your story. I mean, music is life. But it is that universal language. It's so trite, but it's true. And, how did I learn about politics at first? Rage Against the Machine. How many of us did? So there is so much power in that.
And there's so little political music right now when we really need it the most. and that was part of it for me too. It's that I would hear someone do a political song, and at least most big name artists. Now, thankfully, I'm aware of so many great people that are talking about what needs to be discussed. But all the heavy hitters, Public Enemy, Rage Against the Machine, System of a Down, they're quiet. And that was always so frustrating for me, which was another reason I was like, you know what, especially with what I do, if it's spoken word and there's a beat to it, or it's like, I know some of it is kind of alternative hip hop or something. So many people just go right to Hamilton and Hamilton comparison, which it's, you know what, if my contribution to music is that some people could hear someone do something and go, oh, that kind of sounds like Jesse Jett, instead of, hey, that sounds like Hamilton, then I've done my job. we obviously need something else political so people can stop comparing everything to Hamilton.
Yeah, let's not do that, you guys.
And it's interesting is I don't try to push my music in music spaces. I focus it in political spaces, because if you say, here, listen to my record, and then people start listening and go, oh, wait, it's political, then they can hit a wall. But if people know they're in for politics and they're like, oh, wait, there's music too, cool. It's just like an extra little bonus. So
true. Well,
yeah,
much love to you, Jesse. Thank you so much for being so receptive. The second I asked you, you're like, yes, please.
Absolutely.
And you get
I
so
I
excited.
still have my beret from doing the Columbus Medicare for All March, and it was one of the most amazing experiences.
What is it?
Yeah, my beret from the Columbus Medicare for All March from this summer is right on the couch behind me. And I that performance, getting to play at that march, that was the first moment I got to do any of my political pieces to a crowd, let alone to a receptive crowd. And that was that intersection of like getting to perform live, which I've done before, but doing these songs. And I was like, this is what I have to be doing. That was such a galvanizing moment for me. So yeah, anything Medicare for All needs, I'm there in a heartbeat.
Yeah. Okay. So you will be taking over. You're going to play for about 30 minutes and then do not leave. I'm going to take it back and we're going to go over some more things. So thank you, Jesse.
Sounds
Take
good.
it.
Thank you. All right. So I actually just mentioned the first piece that brought me to Twitter, and that seems like a good place to start out. I'd actually mentioned earlier today that with the censorship going on and some of the accounts we see dropping left and right, that I need to start kind of treating every platform I'm given like it's my last potential platform I'll be given. So with that in mind, I tried to really condense everything I would want to say, especially mentions of our healthcare situation or lack thereof. So this is the first song of the night off of The Virus. This is called Town Hall.
In these days of global disaster, all the money disappears with the fame. I'll say what I want, then burn my masters, and I suggest you do the same. Hear my words, but don't breathe the air. You and I needn't speak to share. I'm so sick of the waiting now. I feel sick, so I'm laying down. Hear my words, but don't breathe the air. You and I needn't speak to share. I'm so sick of the waiting now. I feel sick, so I'm laying down. Laying down. Alright, I won't name names, so we won't call legal. We'll call him Bo Jiden, and he killed Glass-Steagall. He's on the trail, off the rails, profits over people. But I won't call him a Nazi, cause I haven't seen his eagle. But I have seen his equal, and he just left the White House. I've seen his equal, and she lost the fight twice now. I've seen the evil in a man who'd shake the hands of workers, knowing they were slaving for a feeble wage and little purpose, all to keep afloat his bloated lifestyle. All to keep us focused on our phones in the meanwhile. So if I'm a broken record, this has been a time trial. But I will not go quietly into the future I'm supposed to hand to my child. I will not politely hold my tongue when I see voters in the web of suppression. So I'm about to burn the list of things we shouldn't mention. Alzheimer's causes bouts of both confusion and aggression. Causes sentences that fall apart in paper-thin patience. Well, I have not spent the past 4 years practicing critiques only to need them for the next administration. And part of me would love to vote for Trump to really stuff you Biden diatribe junkies who would tie me to a chair to watch him push out Bernie Sanders, say he needs to just accept the loss, have your little celebration. Well, I don't know about you, but I had too much love for this misguided nation. So I can't take another president who treats the world like he's a wealthy tourist, just too good to talk to us Haitians. My only choice should not have to be trading one president who chews at the Achilles heel of race relation, who played up all our prejudices, fears, and darkest motivations, for one who hands us over to the corporations like we've all been sex trafficked. And God, I wish that was exaggeration, but it's just part nightmare, part fascination. It's mostly fascists saying we're a cushion generation, while they got the funding made to lift you out your station, while you miss your shift at your third job because you can't afford your medication. And now the pain of your mobility is tied into the need to keep afloat and keep your family just the side of devastation. Well, honey, here's the catch to immunization. Now you might get to have a say in what they give your baby, but in 20 years your baby better be prepared to pay right through the nose to be inoculated. So don't you be surprised when all your insulin is confiscated, cause someone found a buyer who's prepared to hike the price up even higher. And if you land in a coma, just as well, because you're out the conversation. You're not around to stage a demonstration. You're not around to protest human rights being eliminated. You're not around to protest all these voters being silenced and intimidated. Maybe you can hear it in my intonation. That one man's revolution is another's renovation. One hand better wash the other or it's amputated. And God, I hate to be so black and white, but gray has led us straight into the mist and now the lamp is faded. And I don't think that we have very long before the night is falling quicker than anticipated. Quicker than the stocks crash, quicker than your IRA was withered and emaciated. So baby, why obey the men who solve a crisis that they orchestrated? Why are we so pleased to see a corpse get up and speak that we ignore the way the corpse debated? That he spoke in fragmented misinformation, and that he tried to make an honest man's mistake out of a fabrication. While all the major networks eat it up and tolerate it. So whose side are they on if they can point it out in Trump, but act like they don't see it in the man they want to call our savior? God, who keeps paying you to do such sick, dishonest labor? Oh shit, we do? No shit, me too? Everything you buy will find a way to own or eat you. The companies that feed you fund agendas to defeat you. Strip your wits away, rip your wick away. Ultimately put you in a place you have to loot to feed your kid today. And then detain and beat you. How is such an obvious process not see-through? At least not without a UV light. This year will purge our liberties with zero end in sight. So if you couldn't cast a vote that gave you hope about our plight, if you picked up the pen but in your heart it wasn't right, and you thought about the millions going hungry every night, did you have the guts to write in Bernie, or have the guts to fight? Oh, hear my words, but don't breathe the air. You and I needn't speak to share. I'm so sick of the waiting now. I feel sick, so I'm laying down. Hear my words, but don't breathe the air. You and I needn't speak to share. I'm so sick of the waiting now. I feel sick, so I'm laying down. Laying down. Hear my words, there's no time to spare. We killed democracy, it's rotting in the square. And with its last breath, it cursed the very air with that toxic miasma of class warfare. Convulsions were brief. It seized for a minute, then it ceased to fidget. It was just deep sleep in a citywide gibbet. A lot of sweet nothings like the rations we were given. A film crew followed them into the city limits to document the distribution. A little piece of human interest in the mass confusion. Some nice shots of a clean white van and neighbors helping neighbors with their clean white hands. Never mind the boxes being empty like the cans. Never mind a photo op that didn't feed a single man. And this is nothing you could blame on one single man or his supporting an immoral horde of sycophants. We set the stage, we wrote the play, we gave the man a script and highlighted every line he had to say. We're only in this boat because we chose to sail away. We never poured out the decay, we let it spread. And then we watched the nation warp into the noxious dictatorship it is today. We made conditions perfect. It's almost like we want it this way. Hear my words, but don't breathe the air. You and I needn't speak to share. I'm so sick of the waiting now. I feel sick, so I'm laying down. Hear my words, but don't breathe the air. You and I needn't speak to share. I'm so sick of the waiting now. I feel sick, so I'm laying down. Laying down. Laying down.
And that's Town Hall. All right, we're gonna switch up to something very new, actually, from one of the first political things I put out to something I haven't technically released yet. This piece, this is going to be off of a forthcoming record that I promise I'm working on, and will be out as soon as humanly possible, called The Grift. And this is called The Oil Baron Rescue Plan.
No, it couldn't have been me, sir. I was front row in my AOC t-shirt, foie gras sucking on a press release, sir. My head down, fourth shot, good little sheep, sir. Sit down, sweetie, the adults are gonna speak first. They trust the science and are terrified of research. Here to thank our healthcare heroes, they've been feeding to the burnout feet first. Till suddenly they dip mid-shift, take a header off a bridge. Such a shame, they were really such a sweet nurse. Now they'll never get the card and the cold slice of pizza meant to thank them for their teamwork. And now they'll never get the baggie full of checks mixed, which would be the one reward they'd see for the moms they had to intubate, and all the countless cries of grief since we've been haunted by the specter of the C-word. No, now all the applause for our healthcare heroes rings a very hollow note because we played it out like Freebird. Now the ones and zeros and our fragile checks and balances are checks for all the wealthy who have such unholy talents that we think it's patriotic that we all have zero balances. And re-elect Pelosi, social face our toughest challenges, which is analogous to water for a drowning man. Nancy disregards our impoverished with a spiteful and dismissive little waving of her withered hand. 'Cause 500,000 freezing on the streets is Biden's winter plan. And I bet you swore they told you you were voting for a different man. But really all you wanted was a different man. It didn't make a fucking difference if he finishes the previous inhabitants' agenda and starts auctioning protected land. Nah, Biden's born to leap at any war a donor's check demands. Turns out you can't cure greed once it infects a man. Once they lose respect for human life and focus all their fucking efforts on the oil baron rescue plan. Honey, what are we to Hecuba or Hecuba to us that if she's starving we should give a damn? Nah, why should we be moved to tears if someone isn't eating? We won't even recognize that food is essential to our being. It's just us in Israel who will not guarantee that food's a basic human right. Because starvation is our favorite tool of genocide disguised as sanctioned democratic healing. That's me in the corner, losing my religion, gouging out my eyes and then dancing on the ceiling. Jesus fucking Christ, what a feeling.
And that is the Oil Baron Rescue Plan. This next song will require a little sample action, and my feature of the evening, albeit an artificial one, Franco of Frank Analysis. The day of the Capitol Hill slumber party, he went to attend the he went to attend the protest, and as we all know, he was quickly shouted down by Cori Bush. And I asked his permission to sample the moment where he was drowned out by the music, as he said people still owe money, as they still do to this day, actually. So with that said, this is a song called Love Your Prison, about eating up that big old bowl of incrementalism and loving every minute of it.
It looks to me as though you learned to love your prison. I guess you'd say you made it your own. Who knew that freedom's such a difficult decision? I bet you finally feel like you're home. Home. Right in the center where the halves meet. You were proud of incremental half speeds. You were getting down in that AOC dance line, hands tied, nodding to the backbeat. And you would Secret Service dive in front of any representative alive, being asked for the very bare minimum. And you'll turn into that same kind of hard right villain you detested, should we mention they could ever muster maximum. Cause liberal denial's such a lofty ataraxia, where all your morals take a backseat, not up in the cab, but in hidden panels made by federal human traffickers. If you trust the autopilot, then you're just a sleeping passenger, passively accepting that it isn't us the bastards serve, making peace with all the evil walking on this rancid earth, and seeking unity with those who bound your hands at birth, glancing up at fascists on a bloody dais, thinking they just need a push. No, I'm not a holy man, but I'm praying for a burning bush. Yeah, I know you'd love to look away, but love, you need to look. Honey, there are many massacres this country manufactured that will never make the books. Now here's your fucking book. It looks to me as though you learned to love your prison. I guess you'd say you made it your own. Who knew that freedom's such a difficult decision? I bet you finally feel like you're home. Home. home on the range of excuses, justify some fracking, water down pollution, paint a fresh coat of bipartisan charm over backroom collusion. Your consent is being manufactured by illusions, marketing executives in federal seclusion, working day and night to keep you just this side of lucid, and to be down for calling out abuses. So fuck all these progressives who could speak on revolution once they emptied all your powder out and spit on all your fuses. No, I prefer to judge a leader not by quality of tweets, but the six-figure book deals she chooses. All the donors he betrays, the donors he would gladly take a bullet before he refuses. And all the slogans he reuses, buzzwords he produces that he spews like mucus. Well, two can play at that. So here's the inner dialogue of every time I snap, and it's been fine-tuned to ruthless. And saying politics are useless. Just a bunch of loose lips, tweeting cute shit, power suits, taxpayer booze trips, and bunkers at the ready when the shoe flips. When there will be no news clips, there will just be looks to me as though you learned to love your prison. I guess you'd say you made it your own. Who knew that freedom's such a difficult decision? I bet you'll finally feel like your own. Home.
All right. This next song is off of an album called Inauguration Gift. And I would like to dedicate this one to Mr. Sharif Snuggs, who was the first person that really invited me into the fight for healthcare. Invited me to perform at the Medicare for All March in Columbus last summer. And this song, he told me was a personal favorite of his. And I think he's responsible for most of my plays of this song on Bandcamp. So Sharif, thank you for everything you've done for me, everything you do for the fight. And this is Sharif's song. This is called Ugly Fucking Christmas.
One man's silent auction is another's trial, in a system designed to see you suicidal. And funny, we don't hear a peep out of Kendrick Bay or Jay-Z, but we just see a lot of silent idols with all their heads up their asses, like the fascists made them hide somewhere parallel to Pile Idol. Like they've let us off the lead, but we know that in our hearts we will always taste the bridle. Now I am not JPEG Mafia or honorary PNG Yakuza. Label owns your masters and your masters want their profits up. So they said you couldn't diss Biden, you have to stay silent. So shut your fucking mouth and watch me cough it up. God, I'll kill it, then I'll bury it. I'll piss right on the grave, she said I'll maybe dig the coffin up. Cause they want you and me softened up. That's why they try crying unity. Preach it to my face and watch me catch a case faster than we should have ended qualified immunity. Hide from the truth, I'll pull you out and school you, honey, you can call it truancy. Ash as far as you can see, out across the ruins, let it sink in, let it ruin all your dopamine. I take my haze a wider shade of aubergine. My words are just the go-between for all this fucking acid and an out-of-date famotidine. I say my piece, drop the mic, bleed out all my chromosomes and blow the scene. And I will not be coming back, so love us or leave us or mislead us to Iraq. I'm violence over science if your faith over facts. We're all up for auction, honey, we cannot relax. We coronated Biden and I didn't cut a track. I just stared into the ether, hearing everyone react, hearing that collective sigh of liberal satisfaction, cause you all went fucking batshit for a bigot geriatric who magically regains his faculties to slap your daughter's ass, and even though she's 8, you let it happen. Just like all these fucking garbage politicians serve their kids up on a platter during photo ops designed to let them leech a little power and significance directly from the head slave master, the author of imprisonment, who partnered with the sentencer of innocence, telling you they're here to heal the soul of old America. And clearly that's just code for we are here to watch you starve and serve our bigot benefactors. Now cue the canned Kamala laughter, comma distractor, comma less schools, more jails, more fracking, more wars, comma blood dollars, comma Kamala laughing. Fuck it, honey, more reactors. Biden says build back better, but the man learned better from the likes of those who stood for Jim Crow by the letter. So you cannot convince me that a man who spent a lifetime swallowing the sermons of a guy like Strom Thurmond ends up anything but Kissinger with Mr. Rogers' sweater. So I'm out the party. I won't be coming back. Let them love us or leave us or mislead us to Iraq. Let Kamala deceive us with some sneakers and a laugh, but they will not address the other half. If they acknowledge our predicament, they have to say why they dismissed us. And nobody in Congress has the guts to look this nation in the face and explain how they've let us waste away to afford all the comforts they need to maintain all their opulence and stingy, inhumane existence. So it's gotta be an ugly fucking Christmas. And we will not be coming back. Let them love us or leave us or mislead us to Iraq. On violence over science, if your faith over facts. We're all up for auction, honey, we cannot relax. Not be coming back. Let them love us or leave us or mislead us to Iraq. On violence over science, if your faith over facts. We're all up for auction, honey, we cannot relax. All right.
One more song off of The Virus. And this song, when I wrote it, I did not think anyone was going to really go for this song. I had a feeling this was going to be one of those that was kind of just for Jesse. But I was very happy to have this song end up being something that gets requested in the chat, typically on quite a few interviews and stuff. And I'm really just so so happy that this song was able to mean something to some other people. This is Militia Intent. We're going to take just a second to tune up, folks. I am coming to you live from my basement, and it has taken a decided dip into the chili tonight. Wildly wrong. Much better. My cat doesn't have his ears back. That's always a good barometer. All right, Militia Intent, take 2.
You can keep giving us nothing and think we're bluffing about coming for your heads. No, I play civil if you won't listen, or 50,000 dead. Now we know our mission, we form a militia, make Congress a prison. No, I play civil when all these dead won't make you listen. What's more American than slaying your oppressors? What's more American than liberty or death first? No, I thought we were founded on abolishing the tyranny of those who would starve a village all to live empirically. And I regret that I have only one life to give for my cause now that I can see the cause so clearly. See, I want our leaders, regardless of party, to fear me. That I will pick my targets and assassinate them lyrically. that I will bring them out into the town square, hook them to the pillory and leave them there. And Hillary, I'll see you there. Nah, Hillary, I'll see you there. You can't keep giving us nothing and think we're bluffing about coming for your heads. Why play civil when you would listen to 100,000 dead? And now we know our mission, we form a militia, make Congress a prison. So I play civil when all these dead won't make you listen. Welcome to the fantasy of rhetoric. And welcome to the last of the free speech while we can get it. And I promise you can get it. All you corporate Democrats, second wave Confederates, GOP illusionists and neo-Nazi bureaucrats. And Stephen fucking Miller, I will see you in the aftermath. When all the laws are dust and there's just moral justice after that. I would hunt you through the wasteland if it comes to that. Just so I could rub you in the dirt like a cheap human Brillo pad. I can sleep fine when our beds are burning, Stephen, but I'll turn around and run into the blaze to get my pillow back. As long as I could lay my head down, I can live with that. I can deal with a little ash. I could feel like a little of the old me burn with the bed and the rest of my past. The old world where we all lived and we can't get back. The old world where you didn't give and you'd still get back. Where you could rake in 12 billion and give none back. Well, those days are behind us. The virus will kill all of that. Your wealth is behind us and kindness is meant for the past. Our leaders would bind us and starve us and call it a fast. Just a sacrament meant for their God that they garnish in cash. They feed it the poor by the hundreds. That's all that it asks. Its hunger is legion and people in need are all it will have. Our only chance is to starve it and watch as it turns on them. You can keep giving us nothing and think we're bluffing about coming for your heads. Can keep giving us nothing and think we're bluffing about coming for your heads. And that is militia intent. All right, I have one more song and then a spoken word piece, and that'll be it for me. This is this song started with, like a lot of these other pieces, just an expression of frustration with the hopelessness we're staring down right now. And then halfway through kind of turned around realizing that at some point, and it's a different point for everybody, that hopelessness and that feeling of powerlessness turns into the anger that you need to force the change, to come together and make a change happen. So this is another song that will be on the Grift. This is called Powerless. They'll gladly pay you by the hour for a minute or so, so you can sign off on the towers where they'll piss on your home. And if you feel like you're just powerless to answer them no, it's 'cause you are. They'll gladly pay you by the hour for a minute or so, so you can sign off on the towers where they'll piss on your home. And if you feel like you're just powerless to answer them no, it's 'cause you are. It's 'cause you are. They'll gladly stagnate living wage, snap the chains and bury it. Labor slaves in rusty cages dragged behind a chariot, led by Mr. Racial Jungle, Joseph R. Iscariot, fighting over scraps as they barrage us all with variants and BuzzFeed clickbait, straight until we're paralyzed, trying to distract us from the concentration camps that Joe had swore he'd close but only chose to amplify. 50-something kids in cages made for 5 to occupy. And no, she hasn't seen the camps, but Harris swears they're paradise. She tells us the facilities are safe, and that right down to the women, they are regularly sterilized. And then she throws her head back and she proceeds to laugh, that sort of heartless cackle you'd expect from someone working steadfastly on behalf of the virus and a Congress full of parasites. And where was I? I was busy cashing every blue check, demonstrating plainly all the narratives expected from the verified. I was busy breeding verbal leeches by the terabyte, trained them to exsanguinate the wealthy while they sleep at night, bleed the oil barons dry and barren, say they showed us how to share and now we share alike. Tell them I contracted rabies from a feral mic, and now I'm just another species losing sleep to noise pollution in these glaring lights, forced to change its habits and adapt to just survive. But now it's safe to say that some of us are thriving in the moment, throwing shit on presidential homes beneath the Paris skies. So if you feel like you're just powerless, I guess you bought the lie. But I can tell they're petrified of our collective might, and I can hear those gentrifiers weeping at the sight of our collective rights. And I only can imagine the intensifying fear of knowing revolution's near, and all that's left to do is simply wallow in the thick anticipation of a rabid bite. And one day you can ask your leaders just what that was like before you grab a slice. So if you think you're powerless, allow me now to change your mind. If you think you're powerless, allow me now to change your mind. See, they'll pay you hourly, tax them each part, and build a shining tower out of loopholes and cards, and tell you that you're powerless to keep you in the dark because you aren't. Because we aren't. You see, they'll pay you hourly, tax them each apart, and make you build a shining tower out of loopholes and cards, where they'll tell you that you're powerless to keep you in the dark because you aren't. Because we aren't. And that's powerless. Whew, I need a cigarette now, I don't even smoke. Okay, I'm closing this out with a piece that actually directly mentions the Medicare for All fight. I wrote this recently after a day I was cleaning a junk drawer, and I found a Kennedy $50, and I started thinking about what we did to the last president that was the likeliest to give us Medicare for all, and who really talked about universal health care. And we all know the tragic end of that story. And moreover, what we do to figures like that we help take down and then twist their memory and what they stood for, and how uniquely American that is. So this is called $50. This is a spoken word piece that will be on the Grift as well. Again, I'd like to thank everybody that hung out tonight and stayed up late with me, and everyone that watched today. Please come back tomorrow and Sunday, because it's just going to keep going. And again, thank you to everyone putting this together for asking me, and it was a genuine pleasure. So here we go. This is called $50. I found $50 in a dresser drawer. I spent the time I would have spent just staring at the floor, staring down at JFK, trying to imagine the immoral sort of irony that makes a nation feign commemoration of a man that it had murdered by the CIA, and trying to envision us if we possessed the healthcare he had talked about in '58. I guess the takeaway is it's a piece of fucking cake to celebrate somebody's bravery once you've assured they're safely in the grave. And I bet if Pat Tillman were alive today that he would say the same. And I'm sure we're in for more if they let Julian decay. I bet that they would put him on a quarter,
I bet what they would name conference rooms in his honor at the IMF, the New York Times, the FBI, and Citibank. I guess the takeaway is it's a no-risk softball pitch to uplift somebody's image once their image is the one thing that remains. And the worst is when it's coming from a figurehead who's funding every agency that authored the remains. The agency that obfuscates the facts and spins a constant storm of shifting blame. I guess the takeaway is that America will sing your praises loud as day to celebrate the fact you and the threat you posed have passed away. Shit, they'll throw you a parade, and business just as usual will live another day, and all of the insurance gods will bathe in all the praise and make donations rain. And all their winged, wicked little lobbyists will blow their horns and light the flames. The ceremony starts, and they in single column march up to the weathered onyx arch and sand the marker down that bears your name. So you no longer are and never were until your hideous rebirth within the corporate frame. Until you're back from the dead and then bound for all eternity in propagandist chains. It's the very ritual that whittled down the legacy of Martin Luther King into a parable on unity for liberals to claim. And once they learned it worked, the world would never be the same. And now it's getting worse. I guess they're dialing in their aim. History is a straight line, but so's a moving train, which is heavily dependent on our infrastructure grade. Now we're building back better in a nation built on slaves, so you can guess the ultimate direction that our pathway to the future paves. They don't want you living, or they'd offer you a living wage. They don't want you feeding any homeless. It's just best to leave them freezing in the alleyway. They don't want you speaking words of hope unto the hopeless, or they'll do you up like JFK. I found $50 in my dresser, and I spent the rest of my whole day depressed because this constant drop in pressure means that you can catch the bends from simply sitting up in bed awake. It looks like 2022 is really not the year for you to have your lives improved. I guess you'll have to wait. But not to fret. Election season's just around the bend. Why don't you go ahead and save the date? So that you can throw yourself before the magistrate and beg to have your family saved. You don't know the people you elect to lead you more than what their ad portrays. You can't tell their offerings of saccharin and arsenic from ordinary aspartame. And you can't really comprehend the kind of greed this country feeds upon until you're Jackie O wearing close to half a brain. And probably the half that would have seen us passing M4A. And all to keep the pieces in their places in the never-ending profit game. All to weave a tapestry of ampersands. Each allows a claim adjuster room to just dismiss you with a callous hand like fuck you in your meds. Fuck you for requesting a procedure that you need so you can stand. Fuck you and your family and your poor demands. So welcome to the land where we'll assassinate a man and then put him all a $50, stadium, or stamp and proclaim ourselves the greatest country ever master planned. Killing off its citizens, enriching all its brands. And that's $50. That's my time. A little more than my time. Thank you, guys.
Sorry, didn't know I was muted. Thank you so much, Jesse. You know I could listen to you sing the phone book pretty much. I always tell you that, and it's true.
That was awesome, brother.
What's that?
That was awesome.
Thank you. Seriously.
Really appreciate it, buddy.
Yeah, absolutely.
Where can we find you? Where can people follow you and get your music?
Twitter is my main place. Anything I'm putting out, I'll mention it there first. And then my Bandcamp, which is JesseJet, jessejet.bandcamp.com or bandcamp.jessejet. It's JesseJet. But I'm also on Spotify as well. But we're Spotify. So yes, Bandcamp. That they've been fantastic to me.
You and Neil Young.
Yeah. Well, no, Spotify, they just don't pay artists for shit. Like literally if I wanted to get enough plays to be able to pay for my Spotify premium membership, I would be a household name. Like it's ludicrous how little they pay their artists. So yeah.
Bananas.
Well,
But thank you so much for joining us.
Of course,
and thank
seriously.
you for for being so eager to say yes when I asked.
Yeah.
It's amazing. And we love you here. We love your music. So
Love you guys too,
Jesse.
seriously.
We appreciate it.
Thank you. I'm happy to do it.
Thanks. So thank everyone so much for watching. Tonight was a really great kickoff. I want to thank, excuse my reading, I'm using my device. I want to thank the first panel, Luke, you did freaking amazing. Also, Claudia, Karen, Andy, and let's see, Dr. Ted, Anna, Steffi. Thank you to Uncle Larry Sanders for giving me that exclusive. Thank you to Cavernacle for your cameo. Thank you to Andy right there and right there for doing all of the tech shit that I cannot do, and so many of us cannot do either. So thank you. It takes so many volunteers to do this 3-day event. So please keep in mind, it's not just those of us who are on camera. There are a group of organizers who you never see on the background.
Shout out to our green room crew holding
Absolutely.
it down.
Yeah, for sure. There's a green room where, oh, okay, no, wait, I can't, that's inappropriate. I've been good all day. So tomorrow and Sunday we have more panels. Tomorrow starting at noon Eastern, I'm going to be hosting a panel on disaster capitalism, which is also going to be touching on environment. I'm going to be sharing 2 clips from my Stephen Donziger interview. I have an exclusive from Marianne Williamson, and then I have an exclusive from Jordan Sheridan as well. We'll also have a panel on racial inequities in healthcare, a panel on disability, a panel on mental health, a panel on healthcare worker stories. And we have a performance by my comrade Timothy Bracken, who played our DC March. So we have a lot going on tomorrow and Sunday. So even if you couldn't watch everything today, please, please, please tune in the next 2 days as well. So thank you all so much for watching. Also, if you can, and forall.org, it has all the schedules and everything. But if you can, I'm going to be transparent. I'm going to keep it real. Many of us have not even raised the money to pay back what we've put on our trust cards from last July. So for every $20 you donate, you're going to be entered into a raffle. And we are raffling off, shipping included, a really badass Medicare for All gift basket. So please check out the website. If you can donate, please do. Anything helps. We also have future actions that we're going to need to raise money for as well. But again, thank you, Indie News. You can subscribe to them. Please do. Thank you, RP. Thank you, Real Progress in Action. Thank you to PNHP. Just thank you, everyone.
Yellow Vest Actions. The whole group of sponsors, just freaking amazing. Thank you so much. And I just I just want to reiterate, Joy, what you were saying about the fundraising the ticker that we've got going across. This is not money that is going into people's pockets. This is money that is going to the cause, to help to pay for the expenses of what we do. Right. This is not this is an uncapitalist society that we have here in this group. Okay. When people are not putting cash in their pockets to do this, this is just to allow us to continue to do these things. Right. And that's
being
the
an activist is expensive.
George Soros has not sent me a check.
He's in arrears. Like, I haven't received shit from him or Putin.
I know. I called his phone and it said it was disconnected. I don't know.
Oh,
I'm still getting my Hillary checks. I don't know. I can't tell you.
I knew it. I knew it.
If you remember, I tanked Nina Turner's campaign last year. I don't know if you heard about that. I was a Hillary Clinton agent, apparently. Yeah, I was getting big Hillary bucks
I'm sorry,
badmouth
Joy
you
and I were
tonight,
in
so-
Russia the whole year. We didn't
Oh,
hear
gotcha,
those words.
okay.
My real name is Svetlana Babush, and I came here to destroy Bernie Sanders campaign. See, this is
Join
why I
the
can't do
NRA.
stuff like this, because at the end of the night, I'm just like.
That's when the impressions come out. Watch out.
Jesse, you've been on my show before. Well, thank you all so much for watching. Again, please
Seriously.
smash that like button, share, all that fun stuff, and we will see you tomorrow starting at noon Eastern.
Thank you, everyone.